The slides doesn't seem to move, Shamya.
It's not going
Yeah,
to.
I think now it's moving. Okay, now you are okay. Now we are okay.
Yes, sir.
Give me a moment. We'll start. Please unshare now.
Yes, sir.
So, warm welcome to all of you. And I thank all the people who have been with us. And today is a very special day. And we have the 300th session on. I thank all the seniors here, Anna sir, Srinivasan sir, Sahai sir, and especially Sridhar sir for helping us through multiple sessions. And today he has taken special interest, and it is all Andhra Pradesh session. And I wholeheartedly thank every one of you for making this possible. And I'm sure we will be inspired to do this as long as possible. Friends, we have 568 cases discussed, which are available on the YouTube for your kind perusal. Today, we have three eminent faculty joining us. Professor Shikumar Ramchandran is expected shortly. And we have Dr. Nikhila. She's an eminent vascular surgeon from Apollo Hospitals, Hyderabad. Kindly introduced by Professor Sridhar sir. And we have Dr. Swaminathan sir. He is a professor and head of the Department of General Surgery at Corona Medical College, Palakkad, Kerala. And I I thank once again all of you for making this event a possibility. And I wish both the students, Dr. Shamya and Ritika, the very best for their presentation. So, as a matter of precedence, we'll take the arterial case first, and we'll have the honor of taking Dr. Shamya to start her presentation. Please introduce yourself, your faculty in charge, and start your presentation. Dr. Shamya, please share your presentation.
Thank you, sir. Good evening, everybody. I am Dr. Shamya Krishna. I am a general surgery postgraduate, second year in Apollo Medical College in Hyderabad. My faculty in charge is Dr. L. Sridhar. He was HOD, professor and HOD of Apollo Medical College in Hyderabad. Today, I will be presenting a case of peripheral arterial disease. Sir, can I start, sir?
Faculty, please take over. Nikhila ma'am, Kanna sir, Srinivasan sir, Rajiv Sakai sir, please.
Sure.
Yeah, please start. Make it
Yes.
full screen, please.
Yes, sir. I'll start, sir. So today I will be presenting a case of a 62-year-old male resident of Hyderabad who came to our
No, your
OPD
slide
with,
is not moving. Dr. Shamya, your slide is not moving.
Put it on
uh,
slideshow, Amma.
sir, it is on slideshow now.
No, we can't see it like that.
Oh, is it? Let me just redo it, sir. Sir, are you able to see now, sir?
No, we can just see a first slide case presentation. That's it.
Uh,
I think we'll have to log in. Yeah, got it. Yeah, we've had it. Got it. Now make it
What
full
is
screen, please.
peripheral artery disease?
Hello. Yeah,
What?
make it full screen, please.
yes, sir. So can you see it, sir?
Yeah, we can see
Yeah.
it, but can you make it full screen?
Yes,
What
sir.
is
I actually
Go to
made
the
it.
screen share, full
Yes,
screen
sir.
mode, ma. Go to the slideshow mode.
Sir, yes, sir. It is on
There is a
slideshow.
view button on the top right.
Yes, sir. It's on view in my desktop, sir. I'll just once redo it, sir.
Yeah, redo it, please.
No, you please unshare now.
Yes, sir.
Yeah.
You please shut down all your
What is
presentations on your desktop.
Yes.
what is peripheral artery disease?
One
I
moment, sir.
think we'll take the questions. So once the
One moment,
history
sir.
is
One
done.
moment, sir. One moment.
Yeah, please.
Yeah, now press the share button, Shamya.
Yes, sir.
No, you have not shut down this mode at all. Now make it full screen. I said shut down all the presentations, then just share your screen. Not this one. Please unshare now.
Okay, sir. I understood, sir. Yes, sir. Right. Okay.
Yeah, shut down all these things, whatever windows you have opened.
Yes, sir.
Now press the share button. You tell me what are things coming.
Yes, sir. So can you see
You
the?
press the whole screen mode. Yes.
Yes.
Desktop, whole desktop.
Yeah, that's it.
Yes, sir. So can you see, sir?
Good luck.
Yeah.
Yes.
Go on.
Thank you,
Good
sir.
luck. Good
Yeah.
luck.
Good.
Yes, sir. Yes. So I'll be presenting a case of a 62-year-old male resident of Hyderabad who came to our OPD with chief complaint of pain in the right lower limb, in the leg and in the foot, especially for the last 6 months, and complaint of blackish discoloration of right great toe for the last 15 days. History of present illness. My patient was apparently asymptomatic 6 months ago until he felt pain in the right leg and in the foot while walking. Pain was insidious in onset and progressive in nature. To describe the pain, it was cramping in nature, which used to appear in the right calf region after walking for around 500 meters, which made the patient to take some rest for the pain to get relieved. Gradually, for the last 2 months, patient experienced pain even at rest. He also noticed blackish discoloration of the right great toe, which started at the tip and gradually progressed to involve whole of the great toe in a span of 15 days. This blackening was associated with pain and tingling in the adjacent area of the blackening. There was no history of trauma and no history of any discharge from the toe. There is no history of similar complaints in the opposite limb. And there is no history of fainting, any transient blackout, any recent chest pain, weakness or paresthesias in the upper limb, any history of blurred vision, abdominal pain, or impotence. Coming to the past history, there was no history of similar complaints in the past. Patient is a known hypertensive and diabetic since the past 10 years, and he was on medication. He's a known case of coronary heart disease, and patient underwent CABG 7 years back. Family history is not significant. Coming to the personal history, patient takes a mixed diet with adequate appetite and disturbed sleep due to the pain. Bowel and bladder habits are regular, and he is a known smoker for the last 20 years, and he smokes around 10 cigarettes per day, so that's 10 pack years, and he stopped 4 months back. To summarize my history, I have a 62-year-old male who is a known smoker, known hypertensive and diabetic, with history of coronary artery disease, status post CABG, who came to our OPD with complaint of pain in the right leg for the last 6 months and complaint of blackish discoloration of right great toe for the last 15 days.
Okay. What's the provisional diagnosis?
Sir, I am thinking it's a peripheral arterial occlusive disorder. Or
What are the peripheral artery disease?
Sir, it could be Burgess disease, sir, or atherosclerosis.
No. Hang on. Why Burgess? Why
Which
Burgess?
which
Why
which
Burgess?
which arteries?
Why?
Uh, Femorals, popliteals, and below, sir.
So without examination, we will not be able to identify which
Yes,
artery.
yes, sir.
So it's very difficult. So you say
It's
that.
the
Without
differentials.
Okay, but Dr.
no,
Kshamya,
Yes,
depending on, you have talked about the claudication, right?
yes, ma'am.
So if you had to go out on a limb and you needed to talk about the level of your PVD based on claudication in the foot and the calf,
Yes,
what would
ma'am.
your guess be?
I would suggest, I would expect the lesion to be below the knee, ma'am. Like
Below the, but you're
a
saying calf.
femoropopliteal or an
Yeah.
infrapopliteal, ma'am.
Okay. Okay. And what are the, I think sir asked for a couple of other differential. Sir, did you say anything about a differential?
no. I just wanted to ask her why Burgess in a 62-year male.
Correct.
Yes, sir. It is
Why
unlikely,
Burgess?
sir. It is not my
No,
first diagnosis,
exactly.
sir.
So
Before
that was your
differential.
first differential.
My first differential is atherosclerosis, sir, because he has the risk factors, sir, and he's an older male.
What do you
Okay,
understand by claudication?
Claudication is a cramp-like pain, sir, which is felt after walking for a distance due to anaerobic metabolism, sir, which makes the patient to stop walking, sir, and the pain is relieved after a rest.
So you mean that the claudication, the pain will become okay after walking?
No, sir. After rest, it will decrease, sir.
So what are the various grades of the claudication?
There is a Boyd's classification, sir, grade 1 to 4. So, grade 1 is where the patient starts walking and experiences pain after a distance, and patient continues to walk and the pain subsides, sir. In grade 2, the pain persists, but the patient continues to walk. In grade 3, the patient has to take rest for the pain to subside, and in grade 4, it is rest pain, sir.
You think in the Boyd's classification, rest pain is a part of claudication?
Uh, no, sir.
It is not the part of the
Yes, sir.
Boyd's classification.
Yes, sir.
Okay, just let me
What is
ask
the
you. Sorry.
claudication distance in your patient?
500 meters, sir. But it progressively got lesser, sir.
Okay. Okay, Dr.
Okay, you said that in Boyd's classification, the degree 1, there's pain and then the pain disappears while walking. Why does that happen?
So due to the washout of the substance P which gets accumulated, sir.
Is that? What about collaterals? Is there something to do with collaterals?
Yes, sir. If there are good collaterals, the pain
Right.
gets relieved, sir.
It is because of collaterals rather than
Yes.
being washed out, right? We have
Yes.
good development. Okay, you've heard of chronic limb ischemia.
Yes, sir.
What are the components of chronic limb ischemia, and what's the importance of that?
Chronic limb ischemia is defined
Hello.
as rest pain which lasts longer than 2 weeks, sir, despite analgesia, and it can be measured with using ankle
No, where did you
brachial.
get this 2 weeks? Where did you get this 2 weeks from?
Sir, it's a given definition.
No, acute limb ischemia is defined as loss of sudden perfusion for up to 2 weeks.
Okay.
Chronic limb ischemia is 6 weeks.
Okay.
If I think I'm it should be like that. So it
Okay.
is more than 6 weeks
Right.
of limb pain. Then what else is the component of CLI?
The ankle brachial index, sir, less than 0.4,
Now,
sir.
now it's a clinical condition. You don't have any measurements there. Critical limb ischemia is chronic rest pain, right?
Yes,
And
sir.
recumbent
Ischemia and
pain
ulceration.
and any skin changes,
Yes, sir.
including frank
Ischemia
gangrene.
and ulceration and gangrene.
So, so your patient is in having chronic limb ischemia,
Yes, sir.
right? Now, what is the importance of chronic limb ischemia?
Sir, the patient needs intervention, sir,
Why?
because the limb is threatened, sir, and
Right.
there's yes,
So,
sir.
if you don't intervene now, the patient may lose the limb.
Yes,
This is the importance of chronic limb ischemia. What
yes.
is pregangrene then?
There'll be changes over the toes, sir.
Mhm.
Like pale, the toes will be pale, sir, and pallor
So
would be
the
present.
four components of pregangrene. What are the
Um,
four components? Your patient
pale.
has rest pain.
Yes, sir.
There should be edema.
Okay, sir.
There should be hyperesthesia, and there should be color change.
Yes, sir. Okay.
Right. Now,
Yes.
what is the importance of pregangrene then?
The patient may progress towards gangrene, sir. So
Right. So this is the point of
we
return. If you intervene now, the patient, the whole, all the changes can revert, and the patient will not have any gangrene, will not
yes,
have to undergo any amputation.
yes.
Right. So this is it is pregangrene, and then there's the critical limb ischemia.
Yes.
Okay. Now, what are the risk factors your
Tama.
patient is having?
Sir.
What are the risk factors for PVD in your patient?
Yes, sir.
Tama.
Sir. Sir. Okay. Sir, diabetes, sir, hypertension,
Now, which is the
dyslipidemia,
most important? Okay, let's come to this.
smoking,
Amongst
sir.
diabetes, hypertension, smoking, and what else does he have? Okay,
Yes, sir.
what is the most important of these? Which risk factor is most important?
Smoking, sir.
Yes, it is smoking,
Yes, sir.
right? Smoking. That's the
What
one
is
which which is the cause of most of these problems. So please,
Yes, sir. Yes, sir.
ma'am, anyone?
Tama?
So
Okay, someone's asking
based
her.
on your risk factor, based on your risk factor also, you will be able to figure out the
Hello,
level of the
Shamya.
Yes, sir.
PVD.
How will you differentiate between neurological claudication that's from the vascular claudication?
Sir, neurological claudication occurs at the first step, sir, unlike arterial, which occurs after walking for a distance, and arterial is relieved by by taking rest for 5 minutes, sir, whereas neurological can be relieved by a separate posture, as in bending forward, sir, if there's any stenosis.
Yeah, Dr. Nikhila, you asked me something, or should I?
No problem, sir. So, based on your risk factor, also, if you're talking about hypertension or smoking or diabetes, based on that, also, you will have the level of disease,
Yes, sir.
right? So, if you're talking about a diabetic patient, you know, usually you will end up
Yes,
encountering a BTK lesion, which is
yes,
below the knee, which is the
intrafloppy. Yes, sir.
right? And if it is a smoker, then you know it is aortoiliac or femoropopliteal. So it's
Yes.
just to get you a basic idea.
Yes.
Okay?
Okay, Dr. Shamya, I say this is a diabetic foot.
Okay.
Mm.
Prove me wrong.
Uh, so there is no
He's got
history of
diabetes,
trauma, sir.
right? He's got
Which
diabetes and
yes,
a gangrene. Why are you calling it peripheral arteriosclerosis?
yes, sir. There's no history of trauma and there's no history of discharge, sir.
No,
So
trauma, discharge, diabetics don't give history of trauma usually.
uh,
Discharge also can be there in any, it can be there any with this.
yes, sir.
Most important, the patient has undergone CABG.
Yes, sir. Other arterial involvements.
So it's a global disease,
Yes,
arteriosclerosis, right?
yes, sir.
Okay, right. And has the patient doesn't have any other arterial problem?
No, sir. As no, sir.
Okay. Let's go to your next slide. Look,
Uh,
past history, known diabetes, hypertension is not past history. Still diabetic, he's still hypertensive. How can it be past
yeah.
history? It is medical history.
Medical history. Yes, sir.
Not make it as past history. Mixed
Yes.
diets, disturbed sleep. Why disturbed sleep?
Sir, he was having pain during the night, sir. So he
Why do
complained
these
of
patients
disturbance.
have pain at night? Why not
Sir,
at daytime? Why do they?
yes, sir. So when the patient is supine, sir, it aggravates the pain, sir.
You it should go by gravity. It should go back. The blood should recirculate.
Yes, sir. On dependent position, the pain.
Well, he can sleep with his leg hanging. Why
Uh,
does it happen at night?
Shamya,
yes, sir.
Because
Hypoperfusion, sir.
because the
During the
night is cooler. You
yes,
see these patients, they sit with their palms gripping their foot,
yes, sir.
isn't it? It's cooler,
Yes,
so there is vasoconstriction.
yes,
Also, at night there's nothing to distract him. His whole attention is on that pain.
yes, sir.
Okay, so that's why.
Yeah.
Sir,
Shamya,
please.
Yes, sir.
yes, the tobacco has got tobacco glycoprotein, which vasoconstricts the vessels. Okay,
Yes, sir.
so that leads out to more vasoconstriction.
Yes, sir.
Okay,
Yes, sir. I got it.
thank you, sir.
Okay, okay. Should we go uh, to the examination? Okay, let's go to the examination.
Yes, sir. I have examined the patient after taking consent in a well-lit room with adequate exposure. My patient is conscious, coherent, and cooperative, well oriented to time, place, and person. He is moderately built and nourished, and there is no sign of pallis, icterus, cyanosis, clubbing, and lymphadenopathy. Coming to the vitals, the blood pressure is 140/90 mmHg in right arm in sitting position. Pulse is 80 per minute in right radial artery, regular, normal volume. There is no radio-radial or radiofemoral delay. Respiratory rate is 20 per minute and saturation is 95% on room air. Examination of bilateral lower limbs. Patient is lying supine on the bed with extension at the hip and knee joint. On the left lower limb, there is a scar of the previous CABG. Otherwise, it was normal. Inspection of the right lower limb. There is no apparent shortening or lengthening of the limb. There is no deformity. There was a gangrene of right great toe extending till the base of the great toe with line of demarcation from the surrounding skin. Here's a picture demonstrating the same. Muscle wasting was seen in the calf region. Skin is stretched and shiny with loss of subcutaneous fat, loss of hair, and brittle nails were seen. There was no ulcers, scars, or sinuses or engorged veins. Edema was present up to ankle. Burgess angle was 30 degrees. Capillary filling time is delayed, and venous filling time is also delayed. Palpation, all inspectory findings are confirmed. The right leg in the lower one third is cold compared to the left leg. Gangrene of the right great toe is present with line of demarcation at the level of base of great toe. Capillary refilling time is delayed and there was no inguinal lymphadenopathy. Coming to the pulses, in the right leg, in the left leg, all the pulses were palpable. In the right leg, femoral artery was palpable, popliteal artery was feeble, and I was not able to palpate anterior tibial, posterior tibial, and dorsalis pedis artery. The neurological examination is normal. Coming to the systemic examination, per abdomen is soft and non-tender. Cardiovascular system S1, S2 sounds were heard. Respiratory system bilateral air entry was present and clear, and in central nervous system there is no focal neurological deficit. To summarize my history and examination, a 62-year-old male, known smoker, diabetic and hypertensive with a history of coronary artery disease, status post CABG, presented with claudication pain in the right leg for the 6 months and blackish discoloration of right great toe for 15 days. On examination, dry gangrene noted over right great toe with signs of chronic ischemia over right leg with absent anterior tibial artery, posterior tibial artery, and dorsalis pedis artery pulsations. Provisional diagnosis: peripheral arterial disease of right lower limb with digangrene of right great toe with occlusion at infrapopliteal level, secondary to probably atherosclerosis.
Dr. Shamya, I've
Yes,
got a few problems with your examination. Let's go to your first.
yes.
Look, what is the hallmark of dry gangrene versus wet gangrene?
Line of demarcation, sir.
That's it.
The dry gangrene will be dry, shriveled, mummified, sir.
Obviously,
Whereas,
obviously. No, no, no.
yes,
Give me something more substantiative. Dry gangrene, of course. Dry gangrene is dry skin.
yes,
That doesn't give me any information. Smell, which you
yes,
have
sir.
ignored, which you have not noted at all.
Okay, sir.
Was
Yes,
there
sir.
any smell or not?
No, sir.
Right. So
Ca-
that has to be put.
Okay, sir.
That has
Yes.
to
Can,
be. It is
can you
very
describe
important.
what is that line of demarcation?
Um, I'm sorry.
Yeah.
What
Let's
is
go to
that
your
line of
to
demarcation?
your picture. Show you also a picture.
Yes, sir.
Like it belongs to dead tissue or living tissue?
Sir, it's granulation tissue, sir.
Granulation tissue. What do you mean by granulation
Okay.
tissue?
What happens at that line of demarcation? What happens?
There will be
That's what some
hyperemia
to.
and paresthesia, sir.
So it is a living tissue or
Okay.
dead tissue?
Living tissues.
Living tissue. It's
Right.
growing inside there. So your patient has a circumferential line of demarcation is there?
Yes, sir. Even on the plantar aspects.
What is the distal also? It is black.
There was just a small discoloration, sir. But
What do you call that? What is that called? The
Is
lesions,
it
that black thing
such a big
proximal to it.
area will be the line of demarcation?
What is
Don't
that
just
called?
because it is a dry gangrene, try to put these terminologies. Line of demarcation is there. What is shriveled? What is mummified?
shrunken, sir.
Okay.
Shrunken.
Mummified. And also you said there are chronic signs of ischemia. What is the sign of ischemia present in your case?
Sir, there was the skin over the calf and in the leg, sir, was stretched over the leg, sir, was stretched, and there
How
was
how they how in ischemia it will stretch? What is you get a skin being stretched in a ischemia?
What
Who
happens
is
to the
stretching
skin
the
in
skin?
ischemia? What happens to the skin in ischemia?
will
It
be
can never
pale,
be
sir,
get
It
pale, sir,
becomes
stretched.
thinned out.
thinned
Thinned
out.
out.
Yes, sir.
It is
Right.
thinned out. It is dry. It cannot be shining that. And you said there is a muscle wasting in the calf. But what is in the web
Yes,
space? What has happened to the where is the first? What is which muscle will go for wasting first? You
extra,
must see for the small muscles in the
extra.
foot.
Okay, sir.
And can you explain? You said below popliteal and their vessels are not functioning. Then why the big toe alone has got gangrene?
Could be
And you are
progressive,
not
sir.
explained
No,
about
no, no, no.
the
There's something called angiosome. You know
Angiosome.
what
Yes,
angiosome?
sir. Yes, sir. It's basically a three-dimensional block of tissue, sir, which has skin, subcutaneous muscle, and bone, which is supplied by one particular named artery, sir.
Right. So which artery is supplying the great toe? Which is the main artery of the foot?
Dorsalis pedis, sir.
No, it is
Okay.
not.
Yes.
Which is the main artery of the leg? What are the arteries in the leg?
So there's anterior tibial and posterior tibial, sir.
only
That's
two
it.
arteries.
That's it.
Posterior tibial is peroneal.
No, 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 no.
And
No, 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 no. Hang on, hang on.
okay,
Anterior tibial, posterior tibial, and
peroneal, sir.
right. Now tell me which is the main artery of the foot, of the leg. First, tell me which is the main artery of the leg. Is the
Posterior
posterior
tibial.
tibial,
Posterior
and
tibial, sir. Yes.
posterior tibial is the main artery of the foot,
Okay. Yes, sir.
right?
Three
And
angles.
this great toe, the angiosome belongs to the posterior tibial,
Yes.
right? Okay. Sir asked you about those black
Say
lesions
about
proximal to the dry gangrene. What is that called?
Skip lesions, sir.
Yes, skip lesions. So what does that tell you? Does
That
that make it dry gangrene or does that make it wet gangrene? Skip lesions are seen in dry gangrene or wet gangrene?
dry ganglion.
No, it's seen in wet gangrene.
Okay. Yes.
have you talked about the temperature of the skin?
Yes, sir. It is cold, sir, compared to the left leg.
Where you are written?
Yes,
It's in palpation.
Shamya, you should
Yes, sir.
compare both the limbs together first.
Okay,
Both
sir.
the color, the girth, the integumentary system, the skin, the nails, the hair, everything,
Yes. Okay, sir.
right?
Again, your
That has to be done.
popliteal artery is also blocked, no?
Sir?
There is no blood supply in the popliteal artery. You couldn't palpate. You could palpate.
She
See,
says,
yes, sir.
look,
Hmm?
popliteal artery is very difficult to palpate even in normal people. A feeble
Yes,
one
sir.
is hardly, you can say, is hardly palpable.
Hardly pass.
So
Yes.
I take it with a pinch of salt that you could palpate a feeble popliteal. Leave it
Yes.
for the Doppler.
How did you check for the capillary refilling time?
Sir, by pressing on the pulp of the toe, sir, for 5 seconds, and or on the nail bed, sir,
Your
and
big
then
toe has a gangrene, no?
sir, the other toe, sir.
Other toes you could see. Anyway, it's late. How much?
Sir, it was 8 seconds, sir. 8 to 10.
8 seconds.
Little bit delayed.
What
That
is
makes
dry?
no sense.
What is dry gangrene?
Sir, dry gangrene occurs due to arterial insufficiency, sir. Where
Wet gangrene? Wet
wet
gangrene?
gangrene usually due to venous stasis and art infections, superseded by infections.
It is infected, infection. It can be because of venous, it can be arterial, it can be anything,
Yeah.
right? Yeah. Okay, Dr. Shamya, also in a
Yes.
general examination, there are some clear markers for atherosclerosis
Yes.
clinically, right? What are those clinical markers for atherosclerosis, which tells you that the patient has atherosclerosis on general examination? Xanthelisma,
Okay. Yes, sir. Yes, sir.
right?
Yes, sir.
Arcus
Senalis.
senalis,
Senalis. Yes, sir.
right? Okay. There are many other things. We'll go through that again. Okay. Next slide, please.
Yes.
So you should have a picture of both the limbs together,
Yes,
right?
sir.
What about his gait?
Why
Did he
there is
mention anything
edema?
about his gait?
Yes, sir.
You said there is edema in the foot.
Yes,
Can
sir.
you
Up to
explain
the
the edema? Why
ankle.
there is edema? Why there is edema?
Could be.
It is a PVD where there is a arterial supply is lost. And why should there be edema?
Yes.
There are two reasons. You can explain that. One is, I mean, again, what you are thinking, if it is an associated Gauger's disease, the venous disease will be involved. Second, the people who have dry gangrene always keep the leg in a dependent position.
Yes,
Yes.
that's
That
it.
is the reason why you can get an edema. You can still like, but this is what in the examination we want you to explain your findings and what is the finding you are making and how do you justify the findings which you are going to make.
Yes.
And
Yeah,
you
so
said
it
the
is basically,
calf muscle is wasted, no? Calf muscle, something you said.
Yes.
Muscle wasting in the
Yes.
calf region. How do you get a
Yes.
calf region muscle wasting? How do you measure that?
Sir, by measuring sir, on inspection, the wasting was visible, sir, and we can confirm with,
Patient is normally working, no? Patient is normally working.
yes, sir, but he was ambulatory. He was not ambulatory for the past few days, sir.
why? Why? Have you told any history? You've
No,
not
sir.
said mentioned anything about
You
his
said
gait
your
and ambulation.
Gate.
claudication distance was 500 meters.
Yes,
Yeah. Why should he be non-ambulatory now?
sir.
No,
To
there must
the,
be some reason why he's not moving from out of his bed.
it was mainly due to the pain, sir.
The rest pain? Is it because of the
So
rest pain
this,
that he wasn't walking?
Patient is having a wrist pain.
Yes,
look, what is rest pain on walking? It is either claudication,
claudication,
which if is continuous becomes rest pain.
rest pain.
When the obstruction to the arterial flow becomes so much that it is insufficient to supply the tissue, the patient goes into rest pain.
Yes,
While walking, when there is pain, that means normally
it's
there's no pain, but because when the demand rises, then he gets pain,
What is the
right? So
difference
now
between
tell us
wrist
what
pain
is
and
it?
claudication pain?
sir.
What is the difference between wrist pain and claudication pain?
Yeah, now tell us the difference between the two.
Yes, sir. Claudication pain occurs when the patient is walking, sir, and
Why?
the pain is relieved on rest, sir.
What is the mechanism? Why the wrist pain occurs?
So, due to increased metabolic activity, sir, there's anaerobic metabolism that occurs, sir,
The
and
metabolism
metabolites.
happens place from head to foot. And why only in the foot you are getting the wrist pain?
Yes, sir.
The wrist pain will be occur only 99% you get in the foot, in the
Yes, sir.
feet. Why?
Why do you get it in the foot? Okay, let's come to this basic question. Which is furthest away from the heart?
Foot,
Which
sir.
organ is furthest away from the heart? Your foot.
Yes, sir.
So by the time the blood reaches there, it's all gone.
What is the nerve supply to the foot? Can you tell the nerve supply to the foot?
Plantar nerve, sir, lateral plantar nerve and
Okay.
medial plantar nerve,
So the
saphenous nerve.
focused nerve from the heart will be affected much.
Yes.
Okay.
Okay,
Uh,
okay.
look, Dr. Shamya.
Uh,
When you
Yeah.
have gangrene, all this Berger's angle and capillary refill time, they mean nothing. Why
Right.
do you have to go through all that? Look, you are going to you are going to take an MS exam. It's not an MBBS exam,
Yes.
right? All this thing. Why? What does Berger's angle tell you?
Chronic limb issues. I mean, critical limb issues.
Normally, the limb is okay. When you put it against gravity, the blood flows decreases. That is
Yes.
what Berger's angle. So, fellow is already having gangrene. Will you do Berger's test in this?
Mm, yes.
Does it mean anything to you? It doesn't.
Yes.
It's a futile exercise. It shows that you don't know what Berger's angle is all about. Do you get me?
Yes, I.
So, right. So there are certain tests. You've done it. You think you get a marks for it, but the marks will be cut for it because it shows that you don't understand what Berger's test is all about. Capillary refill time. Why? How does that tell you anything?
Yes.
Do you get me? Venous
And
fill
you,
time delay. All this have got no meaning once the gangrene is set in.
Yes.
We have to know which arteries are. Next slide.
Yes.
you are looked sinus and engagements. Which sinus you looked for?
Uh,
You are written there is no sinus and no engagements. Which sinus you looked for and which engagements you looked for?
um, sinus. Sinus. I'm not sure, sir.
The previous slide you have put, there
Yes.
is no sign.
Just
Yes.
show your previous slide, please.
In postgraduates, what we expect you to clinically examine something and say what you are seeing. Don't put
Yes.
theoretical, all that, which is not necessary. You are not going to look for the sinus there, and you are not going to look for the engagements. And
Yes.
look at the skin and say if it is shiny. It is very unusually a pure PVD limb will have a shiny skin because there is no secretion. Sweat will not be there, and it will be
Yes.
always, most of the time it will be dry. So
Yes.
don't just write what you are learned theory. You write
Yes.
what you are seeing in the case. Exam, we see the case and come for the examination. We don't want you
Yes.
to have a cognitive function. We want you to see the
Yes.
case, examine the case, and tell the findings what is there.
Yes.
Okay. So
Okay,
can you see
next
the
slide.
cuttering of the veins?
E, no, sir. Not. Today.
Suppose there is engorged veins, what do you suspect?
We can suspect any varicosities, sir. But
Varicosities.
any thrombophlebitis if it's involved with any tenderness over it, sir.
No, that tells you that even the veins are involved.
Yes, sir.
No, no, already the blood supply is less. So the vein will cannot be get enlarged, no?
Yes, sir.
Input is less. How can the vein get enlarged?
Yes.
But you can still get when you are suspecting some or malformation is coming.
Malformation.
Arteriovenous communication is coming. So that time your veins can still get an enlarge
Yes.
of that.
Yes.
Or these patients, when they are lying for a long time, they can develop DVT,
Yes.
right? They can develop DVT also, right? No inguinal lymphadenopathy. Why? It's got gangrene.
Yes, sir. But there was no inguinal lymphadenopathy, sir. So probably it is
Why?
not
Why?
infective, sir.
No,
You
so
know,
there must be some.
which node, ma? Vertical
Just,
node or
just
horizontal nodes?
Vertical node, sir.
Vertical.
because even the lymphatics could have been destroyed by now.
Yes, sir. Yes,
That's
sir.
why. Next slide.
Yeah.
Okay, this do away with this popliteal artery plus. I can never believe that. Next
Yes.
slide. For abdomen, okay. Rectal, rectal, not done.
No, sir. I have not.
Spine, not examined.
You thought it is a peripheral vascular disease, but what is your upper limb examination?
Upper limb examination was normal, sir. There was no any lesions.
Who will say that? And
Yes.
you are not mentioned about upper limb examination.
Yes.
Okay, what about sensations? Have you tested for sensations in the lower limb? And what sensations
Yes.
do you test? Yeah, what sensations?
Sir, I tested for pain and touch, sir.
What are the other sensations which you have to test for?
Sir, hot and cold and vibration.
Temp and position, joint position.
Joint, yes.
So how do you test for joint position?
Sir, we'll ask the patient to close the eyes, sir, and we'll place the joint in one position. We'll ask the patient to reciprocate it on the other affected.
No, first you show him that this is up and this is down,
Okay.
toe or whatever. Then you ask him to close his eyes and then put it either up or down, right? And then ask him where it is. Where is it? Is it
Okay.
up or down,
Yes.
right? So you have to do a complete neurological examination also of motor, power, and sensation,
Sensitive. Yes.
right? Okay. Is the skin dry?
Yes, sir. It was dry, sir.
Why?
Just
Why
the
is it dry? Why is it dry?
sir, because the skin is thinned out, sir.
Why is it thinned out? No, thinned out is fine.
Yes.
The
It's
dryness has
tropism.
got another reason. Another reason for it. The autonomics also gone, no?
Autonomic. Yes, sir. No, autonomic nervous system.
Okay. Because
Dr.
of diabetes.
Kanya,
Got
what
diabetes.
Yes.
is,
Yeah, please.
sorry, sir, what
No, no,
is
please.
LOPS?
Ma'am, it is a loss of protective sensations, ma'am.
Okay. And then how
Usually,
do you test for it?
um, there'll be a microfilament, ma'am, a
Monofilament.
monofilament test, ma'am. Uh, and there'll be a filament which we will be pressing against particular areas over the foot and the
Different
heel.
areas, right?
Uh, and there are around 6 areas, ma'am.
Correct. Okay, so this gives us a very basic idea as to if he has neuropathy or not clinically.
Yes.
Okay. Go ahead.
Yes. My provisional diagnosis is peripheral
Okay.
arterial. Yes, sir.
Yeah. Now, okay. So how do you progress now? How do you proceed?
Sir, I would like to get a Doppler, sir, arterial Doppler of of bilateral lower limb, sir, and I would like to look for the flow
Suppose
of.
suppose his sugar is 500.
Okay, sir.
The patients come to you, you sent him for Doppler, and the patient collapses there. His sugar is 500.
Right. Sir, I would also send lab investigation, sir.
Right. So first you
Go.
will
Yes.
always, you can't just send the patients for Doppler straight away. Just come to
Mm,
your OPD, you get his investigations and make sure that
yes.
he's okay. And then
Yes.
Doppler is not an emergency,
Yes.
right? Yeah.
I would
Okay.
run
Now,
basic lab tests, sir.
yes.
Like CBP and his diabetic profile, and I would also send for lipid profile, sir, and look for any
Okay, you
TLC.
done that.
Yes, sir.
Okay, done that. Now you sent him for Doppler. You've got a Doppler. What kind of Doppler? What will you write on
Arterial,
the
yes, sir. Arterial Doppler, sir,
of what?
of bilateral lower limb, sir.
Why bilateral?
So to compare it with the other limb as well, sir.
Clinically, you've compared it.
Yes,
The pulses are okay
yes,
on
sir.
the other limb. So why do you want a Doppler on both the limbs? It's just the affected limb.
Yeah, okay, sir. Yes, sir.
So you get an ultrasound of the abdomen done, and a Doppler done.
Yes.
Now, what is a Doppler?
Sir, yes. So, so there was common femoral and superficial femoral, profunda femoris were showing biphasic spectral velocities, sir. Whereas posterior, popliteal, posterior tibial, anterior tibial, and dorsalis pedis were showing monophasic spectral waveforms, sir. And there was an
So what?
atheromatous vessel, yes, sir.
What
Yeah,
is
what is
that
normal
triphasic and
phase?
biphasic?
Yeah, what
Uh,
is normal phasic?
Normal is triphasic, sir. There's
What is
decreased
that?
flow,
What
sir.
is triphasic?
So there'll be a systolic rise, sir, followed by a early diastolic fall, and then a low amplitude throughout the diastole, sir.
No,
So
no,
there'll
what?
be a
That is not. What is the cause of the three phases?
cause. I'm not sure, sir.
Have you seen
What
the
does
three reports
diphasic
that you get?
diphasic tell you? Suppose it's diphasic. What component is wrong? Why is it not triphasic? There's something wrong in the vessel. That's why it's diphasic,
Yes,
isn't it? So what's
yes.
wrong with the vessel?
The elastic recoil during early the
So the vessel is hardened.
yes, sir.
It is hardened. So you
Yes,
have the systolic and the diastolic, but you don't have the elastic recoil,
elastic
which
recoil.
is the third phase.
Yes,
Then you have got monophasic.
monophasic.
What do you mean by monophasic? What is gone now?
Sure, sir. The
Okay.
resistance is increased.
Yes. The
Yes, the
what is the
resistance.
normal flow rate? What is the normal flow rate in a artery in the lower limb? How many centimeters per second?
Not um,
You have
around.
an idea?
No, not sure, sir.
It's between 50 to 60 centimeters per second,
Okay, sir.
right? If it is over 70, what does that tell you? Or over 75, what does that tell you?
Could be an AV malformation, sir.
No.
No. Floor rate.
Poisson's law. If the diameter becomes smaller, the flow
Yes,
rate
sir.
increases. So
Yes, sir.
that
So
tells you
could
that
be
there's a
stenosis.
constriction.
Stenosis.
There's,
Yes.
yeah, there's stenosis somewhere.
Yes.
And if it falls below 30, what does that tell you? That the
I
stenosis is so much that is now it is obstructing the
not
flow,
compensate. Yes, sir.
right?
Yes, sir.
So
I'll,
monophasic is when there is obstruction so much that just the flow, minimum flow is going on. So
okay.
there's no phase. The blood is flowing only through the systolic phase.
Yes, yes, sir.
During diastolic phase, it's not flowing.
Yes,
Do you get me?
yes, sir, I am got.
That is monophasic. Okay. Sir, please. Professor Jayalal. Ma'am.
Yes, sir.
Dr. Kshamya,
Yes,
before
ma'am.
you did the imaging, I was just wondering if you, measured the ankle pressures for an ABI.
Ma'am, I have personally not done it, ma'am.
Okay. What is an ABI?
Yes, ma'am. So it's the ratio of pressure at ankle and ratio of pressure at systolic pressure at brachial, ma'am.
Okay. How do you calculate it?
The norm, yes, ma'am. So for brachial, we will measure the blood pressure in the arm, ma'am, both the arms. Whereas in the ankle, we will measure ATA and PTA, ma'am, and whichever is higher, we will take that.
Okay.
And
Dr. Shamya,
then,
you didn't do ABPR. Why? Give ma'am the answer. I didn't do it. I'm okay. I don't require it.
Yes, sir.
Why? Because there's gangrene already.
Yes, sir. It's
All your
already
tests are gone now. Once the gangrene is established, we know that ABPI is less than zero point 0.3,
1.3. Yes.
right?
Yes.
So there's no fun of doing it. Do you get
Yes.
me?
Yeah, I got it. Yes.
From the
That's the
findings
answer.
which you have said, can you say what would be the angle pressure of your case?
Uh, Sir, it should be below 50 Hg, sir.
You said your Burgess angle is 30.
Yes, sir.
What does it mean?
Sir, it means that there is pallor when the limb is raised to 30 degrees from the
That is
horizontal.
the distance from the heart at which you get it corresponds to the angle pressure to roughly. So now your case is already in.
Yes, sir. 30. Oh, yes, sir.
మంచోడు ఒకటి సరిపోదు అస్మాన్ అంటారు మంచోడు షానవాజ్ కూడా మంచోడు
What about an X-ray? Do you get an X-ray of the foot done?
Suppose you get it 1.2 angle brachial index. What do
Yeah.
you suspect?
చాలా మంది అంటారు మంచోడు పనిచేసేవాళ్ళు మస్తు మంది అంటారు రమేష్ గారు కూడా
Sir, it
మంచోడు
could be vessel calcifications that could occur in diabetic patients. Like falsely
It
elevated.
just shows.
Where
Look,
do
Dr.
you get the
Shamya.
calcification in diabetes?
ఏం
What is
అసలు
Monkey-Burg
విన్నామనే
sclerosis?
విన్న తర్వాత మాట్లాడుతుంది
Have you heard the
Dr.
term
Shamya.
Monkey-Burg sclerosis?
No.
ఏ మాట్లాడు
What is the difference between atherosclerosis and Monkey-Burg sclerosis?
I'm not.
Yeah, tell us that.
Sclerosis you get in a indima. Monkey-Burg sclerosis mostly you get in a media.
Media. Okay.
So
Yeah.
it produces a stiffening. So what is toe pressure?
Toe pressure would
బయట
be usually below 30 mmHg, sir.
So why do you prefer a toe pressure than angle pressure?
So because tibial vessels are usually affected with
So digital vessels may not be affected with the
yeah.
calcification of that.
Yes.
Look, IVPI is greater than 1.2 when the vessels are so hard. Not because of, can be because of calcification, can be because of fibrosis, can be because of inflammation, arthritis, anything. Right? So it's
Yes.
just not calcification.
Yes.
It just means that the vessel walls are so hard that it's like a pipe now. All
Yes.
the pressure of the blood is just going down right below to raise the pressure by gravity.
But in the exam, at least you should say that you have done angle brachial pressure for the opposite limb also, because the examination doesn't stop for only one limb.
Yes.
Or
You have to find out whether the other
atherosclerosis
limb
was
can be
suspecting.
affected or not.
Yes.
Atherosclerosis is a global disease.
Global.
It could be, so you must do an angle brachial index. What is that? Maybe you may not be able to do. Can you do with your stethoscope, or you need anything?
Sir, we'll need the Doppler probe, sir.
So you
No,
said
I
you
can
see
do it
the
without
limb,
Doppler
upper
also.
limb. In which
Is
upper
there a
limb
way
you
of
will
doing
measure
it?
the pressure?
Sir, upper brachial artery, sir.
No, which right limb or left limb? The left leg is on the right side, no, affected.
Sir, ipsilateral answer.
No,
So
again the
left.
same. What you said here in that you measure
Higher
all the three and take the maximum. There
maximum.
also you should see the both and take the maximum of that we take.
Okay. Yes, sir.
Okay, Dr. Shamya, suppose you don't have a Doppler. Can you do an ABPI? Any other simpler way of doing it?
Um, Sir, bell of the stethoscope, sir.
No, you put in a probe,
Okay.
your SPG probe, right?
Okay. Yes.
And then increase the pressure till it becomes zero. The oxidation becomes zero.
Yes.
Right? Do that in the other on the upper limb, and then do it on the lower limb,
I think
Yes.
and then compare the
you can do a
right.
dissertation on that and publish a paper because new
So
things are
there's a paper published by University of Liverpool on this.
okay, great. Then definitely one of my PG will do this.
Yes. Right? Okay, yeah. Next slide, please. Okay, then you've done the Doppler. Now what? It so shows that uh, the
Yes, sir.
the
There's biphasic
arteries are
and
gone.
yes, sir. Sir, I would like to
Okay.
proceed with further imaging, sir.
Mm-hmm.
I would like to get a CT angiography, sir, to look
Okay.
for the site of occlusion and the extent of occlusion, sir, and how is the collaterals distally, sir.
Okay. Have you heard of anything called Task 2 guidelines?
Yes, sir. Task guidelines are
What is yes? What is it all about?
trans transatlantic
Yeah, that's
intersociety.
fine. That's fine. That's fine.
Yes,
That's
sir.
fine. What is
Sir,
it all about?
yes, sir. So we'll divide it into four stages, like four groups, sir, A, B,
Mm-hmm.
C, D, and that will tell us if patient needs endovascular procedures or surgery, sir.
What are the
Okay, very
criteria
good.
to divide A, B, and C? And what's Kumar? What are the criteria by which you depend
Okay,
on which?
Sir, based on
we
the
don't want you to be very specific. Just give us a fair idea about what is this all about.
sir, we'll see the extent of the disease, sir, and
No, no,
based.
hang on. Extent of disease is done by how? How do you know the extent of the disease? What are the
Sir,
factors which you take into consideration?
yes, sir. Like how much segment of the length is in, like of the vessel is involved, sir. If
Single
it,
segment, multiple segments,
yes,
length of the obstruction, right?
yes, yes,
Right, and the kind of obstruction. How much is the vessel surface area, cuts
yes,
cross sectional area being involved, right?
yes.
So that tells us whether you
We
can
have,
do endovascular or endoluminal, or you need a surgical management, or you have
yes,
to do an open surgery,
yes.
right? Okay.
What are the
So
contraindications for
anyone?
doing a CT angio? Straight away go for CT angio. What are the
Um,
contraindications to do CT
yes, sir.
angio?
If the patient is a known case of CKD and the creatinine is high, sir, and
And
Very good. We got some more news for bad news for us. CKD, raised creatinine. Okay.
yes,
if
Now
the
what? Okay, you done? Have you done
second is if
the?
the patient is, you're not planning for an intervention. For example, 8-year-old lady is not moving, she is better done. Then also there's no meaning in doing a CT angio. So unless you're planning for
planning
some
an intervention.
intervention,
Yes, sir.
patient is non-interventional, then also please don't do a CT angio because it doesn't serve any purpose. A Doppler will give you adequate results to see a vascular disease or not. Authorities.
So
Okay,
what surgery
creatinine
will
is
you do for
something.
this patient? What surgery will you do for this patient? Some surgery has to be done.
Yes, sir. Sir, I would like to proceed based on the CT angio findings, sir. I
No,
would
no, no,
like.
no, no, no. Sir just told you CT angio, patient are not fit, CKD, all that kind of. What surgery will you do? CKD, raised creatinine, but you still have to do one surgery.
Sir,
What is
we'll
that?
go for raise amputation, sir.
Right, you got to lop off that gangrenous toe,
Hmm.
right? Okay. And any conservative management, just lop it off and leave it. What is
Sir,
the medical management?
yes, sir. So we'll ask the patient to stop smoking, sir, and we'll ask the patient to start exercising.
Dr.
Along with
Shamya,
that,
Dr. Shamya, your
yes,
patient is 63 years old.
yes.
His wife must have been sitting on his head for last 40 years telling him to stop smoking. He didn't. Do you think by Dr. Shamya telling him to stop smoking, he'll stop?
Unlikely, sir.
Unlikely.
Yes,
So how do you
unlikely.
get him to stop smoking?
Uh,
There's a way.
nicotine.
Dr.
Nicotine
Shamya
patches.
can succeed where the wife couldn't.
Sir?
Yeah, nicotine patches.
Yes.
Right. You got to give him nicotine patches. Okay,
Yes.
what else?
Sir, medical management would be antiplatelets, sir. Along with we can
No,
go for
what is an antiplatelet and what is a platelet inhibitor? Give me an example of an antiplatelet.
yeah, sir, aspirin, sir.
Aspirin, okay.
Flop.
It's a platelet inhibitor. It's not a antiplatelet. It's a platelet inhibitor. It prevents platelets from
Aggregation.
clumping.
Yes, sir.
Clopidogrel and ecosprin are
Aspirin.
platelet inhibitors. Antiplatelets is silastazole,
Silastis. Okay. Yes, sir.
right? It's silastazole,
Yes.
right? Okay, what else?
Um, since-
Okay,
we
Any
can
Soumya,
use
vasodilators?
statins, sir.
yeah, this patient's creatinine is 1.6. What will you
Okay.
do? Will you straight
Sir,
away do CT angio or will you straight away reject for CT angio?
sir, we can give adequate hydration for 24 to 48 hours, sir, and we can also
Okay,
give N-acetyl cysteine.
okay,
And during the and after procedure, and we can then proceed with CT angio, sir, with good hydration. Sir.
yeah, okay. And you have to get a consent for a dialysis if required. Sometimes
Yes,
patient may require 1 or sittings of dialysis also. That also should be there when you're
yes,
taking such a patient for CT angiogram. Okay.
yes,
And fourth thing is there are renal friendly uh, dyes are also there. You can also that thing. Okay.
yes,
Okay. These are the 4 options to do a CT angio in such a compromised patient.
yes,
Okay.
So the drugs to be given are you give statins, you give
yes.
clopidogrel, you may give
Silastis.
ecosprin or silastazole,
Yes,
right?
Silastazole, what's
And
the
for
absolute contraindication?
sir. Cardiovascular.
It's an indication of cardiovascular disease.
Cardiovascular disease. Yes.
No, no, what's contraindication?
Um,
One
You
group of
said he had
patients.
a CABG, right?
yes,
No,
sir.
no, 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 no. That's not a contraindication for CABG patients. If they are
No,
POV, we can
heart
give.
failure, no, sir. Heart failure, we
Heart
don't use
failure.
to.
Heart failure is it's a commonest complication of silastazole.
Head dizziness, headache.
Commonest complication or commonest adverse effect.
Sir, I'm not very sure, sir. It's
Headache.
headache, I think, sir.
30% of patients of silastazole will develop headaches. In that case, you can give analgesics. You can reduce the dose of silastazole and taper to the full dose. That's the way it has to be controlled.
Yes,
So any patient giving silostol should be advised that 1/3 of them will develop headache. Nothing to worry about it. That will settle by itself.
yes,
Okay,
yes.
what is silostol?
It's a phosphodiesterase 3 inhibitor, sir.
Okay. What are the roles of what are the medical advantages of silostol or what is the medical benefits of silostol?
Sir, it increases the CAMP, sir, so
Yeah.
it makes like it increases the claudication distance, sir. The patient is symptomatically better, sir.
Okay. It
okay,
promotes
Dr.
anti.
Shamya,
Sir.
sorry,
Fine, fine,
the
please.
patient is having pain, right? He's got
Yes.
chest pain. So what do you do for that now?
Can proceed with the sympathetic.
What
Um,
is the pain ladder?
WHO pain ladder, sir. So we will be starting with NSAID, sir, and then if the patient is still not
Paracetamol,
paracetamol and
then
NSAID, sir. Then
then
NSAID, sir. Then opioids, sir.
synthetic opioids.
Yes, sir.
Which is a synthetic opioid?
Pethidine. Code.
Which is a synthetic opioid? You use it very commonly.
Fentanyl. Fentanyl.
Tramadol,
Tramadol.
right? Okay, and then opioids. Okay.
Yes.
Anything else, sir? which I'm missing.
What other drug would you give? Anything else? You said antiplatelets.
Yes, ma'am.
You said statins. You said phosphodiesterase 3 inhibitors. Anything else that you would like to add to it?
Ma'am, we can also give pentoxifillin, ma'am.
Okay.
It reduces the viscosity of
Okay.
the blood.
Yeah. Cilostazol better than pentoxifillin, fine. But would you consider adding anticoagulation?
Yes, ma'am.
Okay. So we have now something that we use known as dual pathway inhibition, where we use an antiplatelet and we use an anticoagulant.
Yes.
Okay, in PVD patients. So it reduces the male and MACE, which is what? Major adverse limb events and major
Major adverse cardiac.
adverse cardiac. All
Yes.
right. So this dual pathway inhibition is antiplatelet and anticoagulation. So we give 75 milligrams of ecosprin with
Yes.
2.5 milligrams of rivaroxaban
Yes.
twice daily. Okay.
Yes.
So this is based on the COMPASS trial.
Okay. Yes.
Why these people need ecosprin regularly?
Sir, to prevent
Hello?
any plaque and plaque formation, so like further plaque stabilization.
Ecosprin has no role in plaque formation stabilization. That is by statins only. Statins are important for plaque formation stabilization. Why
Stabilization.
ecosprin? Yeah, ecosprin has no role in plaque formation
Clot, yes,
stabilization.
to prevent any thrombosis, sir.
No. The reason is most of these patients have a coronary illness. Okay, and most of the patients die due to coronary disease. So
Yes, sir.
ecosprin doesn't have much role in a peripheral vascular disease, but
Prevent
most of the patients have a coronary disease. So to
yes.
prevent coronary events, you are giving ecosprin regularly to these patients.
Yes.
Okay, statins are for the plaque formation, plaque stabilization.
Yes, sir.
Okay.
Dr. Shamya, your patient must have been on ecosprin also because go ahead and undergone CABG.
Yes, sir. Yes, sir. Patient is on.
So
He was
that's not
on.
doing him much help.
Yes.
Obviously, it's not helping him. So you have to think of alternatives. Even you give something, you give nicotine also. You give complamina, which is a nicotine derivative. Tablet
Yes.
complamina, which is a
Oh,
vasodilator.
okay, sir.
Right? Yeah.
Right.
Nicotine does help there. Do you know the difference between Berger's disease and atherosclerosis?
Yes, sir. Atherosclerosis affects large to medium vessels, sir. Berger's disease affects small to medium
What is
vessels.
what is Shinoya's criteria?
Sir, it is seen in Burgess, like it is a criteria for Burgess disease, sir. So
Yeah.
it
So what
will
is
be in a smoker, sir, and
yes,
below 45 years of age, sir,
right?
no with no other.
No other diseases,
Yes, sir.
right? Okay. So tell us now. Tell me more differences of between Berger's and
Sir, in
TB.
Burgess, arteries and veins both are affected, sir. Whereas in
Neurovascular
atherosclerosis,
bundle. Hang on, hang on. It's
neurovascular.
neurovascular bundle. The nerve,
Yes,
artery, and vein both,
yes,
right? Atherosclerosis generally affects just the arteries. What else?
arteries, sir. Yes.
What else?
The spread of disease is proximal to distal in
Berger's is
What do you want
basically
atherosclerosis.
an
to do for
inflammatory disease. Berger's is
Sir?
basically an inflammatory condition,
Yes,
right?
yes,
This is
yes,
not an inflammatory. Arthritis is not inflammatory,
yes.
right? Yeah. Okay.
what is patient?
Anything else, sir? I think we're done. Dr. Kanavgal, Shamya, anything you want to ask us?
No, sir. Uh, no, sir. I
You've got, you've got, ma'am, you've got big vascular surgeons there to help you out.
yes. Mm.
Okay, one question. What is Bollinger's scoring system? Have you heard of it?
No.
Oh, it's almost like for task two, right? It's about plaques, stenosis less than 50% and stenosis more than 50%. You got to classify them, okay?
Right.
I mean, just asked you like that. Okay. So should we call it?
Yeah.
Call Dr. Kanavgal. I think who's the next person? Can we Dr. Shamya, can you just log out and then we'll ask the
Yes,
next?
sir. Yes, sir.
Sharma can be there. Listen, you can.
Yes. I'll just call the next.
Who's the next candidate? I don't have the name. Hello.
Sir, me, sir. Ritika, sir.
Yeah, Ritika, come up. Just come up online.
Dr. Ritika, please.
Good evening, sir.
We can start.
Yes, sir.
Yeah. Please introduce yourself and start.
Sir, are you able to see the screen, sir?
No, Abhi nahi. Let me see the patient tomorrow. Not CT.
Sir, is the screen visible, sir?
No,
No.
ma, not yet.
You use this presentation and continue, Dr. Ritika.
Yes, sir. Sir, is the screen visible, sir?
Yes.
Um,
Can we go
Just
for
make it full screen, please.
yes, sir. Good evening, everyone. I'm Ritika, second year postgraduate from Department of General Surgery, Apollo Medical College, and the faculty in charge for today's presentation is Dr. L. Sridhar, Professor and HOD of Department of General Surgery, Apollo Medical College.
Ritika, can you make the presentation mode?
Sir, it is full screen, sir.
No, it is not. Just try it.
Okay.
It may be in your thing. We're not getting it.
Yeah,
Can
yes,
you
sir.
make it again?
Yes,
Can you
sir.
yeah. Just stop sharing and do it again.
Yes, sir. Yes, sir.
Yeah, that's it. Good.
Yeah. Good evening, everyone. I'm Dr. Ritika, second year postgraduate from the Department of General Surgery, Apollo Medical College, Hyderabad. And the faculty in charge for today's presentation is Dr. L. Sridhar sir, Professor and HOD of Department of General Surgery, Apollo Medical College, Hyderabad. Uh, a 41-year-old gentleman, resident of Hyderabad and a daily laborer by occupation, came to our OPD with chief complaints of multiple dilated tortuous veins over the right lower limb for 4 years and pain along the right lower limb for 4 years, blackish discoloration over the lower part of the right leg for 1 year, and multiple small wounds over the right foot for 1 year. The patient was apparently asymptomatic 4 years ago when he noticed multiple dilated tortuous veins over the right lower limb, which were insidious in onset, initially noticed over the thigh, gradually progressive downwards, more prominent at the end of the day, less prominent 10 to 15 minutes after lying down. It was associated with pain, which was intermittent dragging type and aggravated more towards the end of the day, relieved on taking rest, associated with blackish discoloration of the right leg for 1 year. Uh, and also multiple small wounds over the right foot for 1 year. There was no history of trauma, and the wounds were painless with no discharge. There was no history of swellings in the inguinal region, no history of crampy pain while walking, no history of immobilization or recent major surgeries, and no history of any abdominal lumps. Past history, there was no history of similar complaints in the past. Patient is a not known case of hypertension, diabetes, asthma, or CAD. There was no history of previous surgeries and no known allergies. Family history, there was no history of similar complaints in the family and there was no history of hypertension or diabetes in the family. Personal history, patient took mixed diet and his appetite was normal with sleep adequate, bowel and bladder regular, and he was an occasional alcohol consumer. To summarize, a 41-year-old gentleman with multiple dilated tortuous veins over the right lower limb for 4 years, associated with intermittent dragging type of pain, aggravated towards the end of the day, with blackish discoloration of the lower leg and multiple small wounds over the dorsum of the right foot for 1 year, with no other significant history, most probably suggestive of right lower limb varicose veins with ulcer. So, do I proceed with
Okay.
you?
No. Yeah, let's go to your first, to your history. Let's get your history corrected. Okay. So 4 years history
Yes, sir.
with the ulcer on right foot.
Yes, sir.
Is it on the right foot?
Yes, sir.
Where do you expect multiple small wounds on the over the right foot? In varicose veins, where do you expect the ulcer to be?
Sir, in
On the foot?
varicose veins, the most common site of ulcerations would be on the lower one third of the leg, sir, also known as the gaiters area, sir.
You expect wounds or ulcer?
Ulcers.
What is a wound and what's an ulcer? Wound is something which happens by trauma,
Yes, sir.
right?
Yes, sir.
So do you think there'll be small ulcers or I don't know wounds over right foot? You think that would be because of varicose veins?
What else would
So
you
is it on the
consider?
foot or is it on the leg? Is it in the gaiters area or is it on the foot?
It is on the foot, sir.
It's on the
If it
foot.
so, what are the possibilities?
Okay, so
Multiple ulcers, mostly in the foot. What are the
yeah,
possibilities?
what do you think could be the cause?
Sir, it could be because of any trivial trauma, sir, or it could be due to itching, sir, because of uh,
So the itching happens on the foot.
What do you mean by foot? From where to where is foot?
below the ankle. Uh,
So in your patient, ulcers are below the ankle and the dorsal surface of the feet.
yes, sir.
How many ulcers?
Sir, there were two, sir.
Two. Duration?
Okay.
Since 1 year, sir.
So 1 year, a non-healing ulcer with a reasonable mode of treatment. What are the possibilities? The foot.
Um,
Okay, what are the DD of an ulcer foot?
Sir, it could be due to any diabetic ulcer, sir.
Yeah, of course.
Uh, Traumatic ulcer, sir, secondary to trauma.
Trauma for 1 year without any cause.
But you said no trauma, and
Yes,
you
sir.
said the ulcer is in the dorsum of the foot.
Yes, sir.
So
Non-healing.
diabetic foot, you get an ulcer in the dorsum commonly.
Which is a common site for diabetic foot ulcers?
And
What are the common sites for ulcers in the diabetic foot?
grade to second to web spaces, sir.
Where else?
Sir.
Where else?
It's a very simple question, Ma. There is an ulcer in the foot for
He's
more than 1 year,
pressure.
non-healing. What are the possibilities you think?
Because it's not varicose. This also not because of varicose veins. Definitely.
You want to think of vasculitis, Ritika?
Yes, sir. Yes, sir. Vasculite. Yes, ma'am.
What else?
Okay, we'll come to that later on.
Osteomyelitis.
Yes, sir.
Chalo, we'll come to that later. Next slide, please. Multiple tortures. Where did it initially over? Thigh. So it progressed from above downwards?
Yes, sir.
Do varicose veins progress from above downwards or move from below upwards?
From below upwards.
Then, look, Ritika, when you're taking your history and you
Yes,
find
sir.
something unusual, you got to go
Yes,
back
sir.
and correct it. Correct
Yes,
yourself, isn't it?
Yes, sir.
Okay, that's all.
Aggravated towards the end. Why does pain happen
I'm on
in
the
varicose
class,
veins?
that class. Okay.
Why do patients have pain in varicose veins?
Sir, it is
Maybe.
usually at the end of the day, sir, due to heaviness which is noted, sir.
No, so why do they get pain? Heaviness is something, pain is something else. Why do they get pain?
Due to venous hypertension, sir.
Okay, so what is venous hypertension?
Sir,
What is venous hypertension?
increased pressure in the superficial venous system, sir.
That is venous hypertension. If the pressure increases in the superficial system, I see the deep system.
Okay.
It's in the deep system. And why does that happen?
Sir, because of incompetence, sir. That.
What
आपको
happens
क्या
is that
समझना
Systemic
है
pressure.
तुम्हारा समझा
thrombosis.
देना नहीं वो सेंटेंस क्या है बोलना है मेरे को वो सेंटेंस के हिसाब से लिखने आता है मेरे को वही लिखे तो हो जाता है आपको सुनना है वही तो मैं बोल रहा हूँ
So there is thrombosis, then there is recanalization. So the valves get destroyed. And when the patient is standing, all the column of
और
blood
मैं
is
फ्राइडे
right down in
सैटरडे
the below
जाऊंगा मैडम
the
5-6
ankle.
दिन रह गए तो थोड़ा
That
जल्दी
leads to
खत्म
venous
करना है बाकी
hypertension.
का तो वर्क छोड़ दो
Right? Okay. So the pain is because there is edema, the stretching
Yes, sir.
of the legs.
फिर मैं
Yes,
ये
Right?
बुक ये रख के जाता
And
हूँ
that
लैपटॉप
irritates
तुम्हारा
the
उसके
nerves.
पैथोलॉजी और क्रिटिकल केयर दोनों भी पढ़ लो और दोनों आने पे मेरे साथ डिस्कस करना है
Hello, hello. So
Sir.
Samson, sir, associate back discoloration for right leg. The whole leg is discolored.
No, sir.
Okay, let's go to the next slide. Let's finish off with the history fast. Next slide, please. Multiple small wounds, painless, no discharge. Are they increasing in number of size? Are they healing and then reoccurring
No,
in a
sir.
different place, or the same one is reoccurring? Is it an unstable scar? What is it? Multiple small wounds. You got to take a detailed history. Has that
Yes, sir.
wound happened? Did it start with a single wound? Were there multiple wounds? Did the wound heal and then reform, or did a new ulcer appear? Okay, so you got to
Yes.
take a because now we are dealing with something which is not related to your varicose veins.
Yes.
Okay, next slide. Make it medical history, please. Next slide. Okay, next. So, should we go to the examination? Anyone? Ma'am? Okay, examination, please. Examination.
You are now thinking it is a what is your provisional diagnosis? No?
Sir, provisional diagnosis, based on the history, it could be a case of right lower limb varicose veins with ulcers.
So what is the history suggest you of varicose vein?
Sir, there are multiple dilated tortuous veins, sir, over the right lower
All the
limb.
veins are started from the thigh and coming down. That is not the history suggest you of varicose vein.
What does that suggest?
Is there any pain?
Sir, yeah. Heaviness.
Can a
Yes,
varicose
sir.
vein produce
Suppose there
pain?
is.
Sir?
Can a varicose vein produce pain?
Sir, ulcer can produce a pain, sir.
The question is, varicose vein per se, can it cause pain?
No,
No?
sir. No, sir. Heaviness is
Then why
noted,
do you
sir.
want to operate on that?
Because of the complications, sir.
So it will not produce pain, then what it will produce? It's the
Bleeding.
complication of varicose vein.
What happens?
Sir,
What is the sequelae after varicose veins? What will happen?
sir,
Suppose you leave it like that.
yes, sir. It could lead to bleeding, phlebitis, lipodermatosclerosis, skin changes, sir,
It can
and
progress
ulcers.
down to extend down into the deep veins finally.
Sir, sir.
It can produce varicose ulcers.
Yes, sir.
Right?
Yes, sir.
How it produce ulcer? How the varicose vein leads produce ulcer? Okay, you must go back and read more. Varicose vein per se can cause pain. The visceral pain it can produce.
Ritika,
It can produce night
what is
pain. It can
atrophy
produce.
blanche?
So all
Sorry,
that
what is
details you need to study. The basic you must study.
Yes, sir.
Representation. Okay. Go ahead.
What is atrophy blanche?
Sir,
Now that
atrophy
asked you
blanche is another sequelae of varicose veins, sir, where white patches are noted, sir, over the lower limb.
What does that tell you?
It is a sequelae of varicose veins, sir.
Yeah, it is a sequelae of varicose vein, but what does that tell you?
Sir, there is a loss of. Sir.
Yeah, go on. There's loss of?
Venous valvular competency, sir.
That is because atrophy blanche tells you that the skin out here is going to break down in any moment.
Yes, sir.
It is a precursor for a varicose ulcer.
Varicose ulcer, sir.
Because there's a venous obstruction around it.
Yes, sir.
So there's no blood going there, no arterial supply and no venous supply.
Yes, sir.
Venous drainage, okay? So that tells you. That's how it happens.
Yes, sir.
Okay. Next, let's go to examination.
General examination, the patient is moderately built and nourished, conscious, coherent, and cooperative, well oriented to time, place, and person. His vitals are stable, temperature febrile, pulse rate 80 beats per minute, blood pressure of 120 by 70 mm of mercury, respiratory rate of 17 cycles per minute, and a saturation of 98% on room air. There were no signs of pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. On local examination, a patient is examined in standing and supine position in a well-lit room with adequate exposure after taking due consent, sir. On inspection, the left lower limb appears normal with no visible varicosities or skin changes. Right lower limb, there are dilated, elongated, tortuous veins noted over the medial side of the leg, extending from the ankle to slightly above the mid thigh, and there is circumferential dark pigmentation noted from the mid leg about the ankle below, sir, and there are ulcerations of 1 into 1 centimeters noted at the dorsum of the right foot with well-defined margins, sloping edges, and floor covered with pale granulation tissue, and the surrounding skin appears pigmented, sir. On palpation, there is no local rise of temperature and no
no tenderness noted, and all inspectory findings are confirmed. On performing the clinical tests, the Trendelenburg test 1 and Trendelenburg test 2 are positive. On doing multiple tourniquet tests, there is a perforator incompetence noted at the mid thigh and below the knee. Modified Perthes test is negative. Figen's test defects in the deep fascia is noted at the lower thigh and below the knee. And Schwartz test impulse is felt at the saphenofemoral junction. And Morrissey's cough impulse test was absent. There was no palpable inguinal lymph nodes, and distal arterial pulsations were present. And auscultation, there was no buoy heard at the saphenofemoral junction. Systemic examination per abdomen was soft, non-tender, with no palpable masses. Cardiovascular system S1, S2 was heard with no audible murmurs. Respiratory system, there was bilateral airway entry present and clear sound. And central nervous system, there was no focal neurological deficit. To summarize, a 41-year-old gentleman with varicosities involving the right great saphenous vein, complicated with a venous ulcer and lipodermatosclerotic changes. And positive clinical tests include Brody-Trendelenburg test 1 and 2, multiple tourniquet tests, Schwartz test, and Figen's test. Hence, this is the case of 41-year-old gentleman with right lower limb varicose veins involving the great saphenous vein with perforator incompetence and venous ulcer, bearing the modified CAP classification as C6, EP, AS plus P, and PR.
Let's get to your picture. Let's see your picture. You've not shown us the picture of the ulcer. Could you just show us the picture of the ulcer?
Yes.
Look, you in your history have just told us there is dilatation of vein and some ulcers. What about this whole discoloration of the is got florid lipodermatosclerosis?
Yes, sir. Yes, sir.
So your history has not mentioned it at all.
Sir, blackish discoloration was noted since for 1 year, sir.
Where you did? Let's go back to your history.
Yes, sir.
That's what we are all debating about all the time.
Sir.
Blackish discoloration, right leg. Where? Right leg where?
Lower 1/3 of the leg.
Say Gators area.
Yes, sir. Gators area. Sir.
We've been asking you all this while what is happening around.
Yes, sir.
Okay. Which is when you have a patient of varicose veins, which is the first test you do?
So we do a Trendelenburg test, sir.
No, you don't do a Trendelenburg. What is Trendelenburg test for?
To look for SFJ incompetence, sir. And
that is Trendelenburg? That is
Trendelenburg test 1, sir.
1.
Yes, sir.
Right. If the patient has DVT,
sir,
all these tests are meaningless. Right?
Yes, sir. Yes, sir.
So which is the first test you have to do?
We do a modified Perthes test.
Okay. What is the difference between Perthes and modified Perthes?
Sir, in Perthes, when we look for deep vein thrombosis, sir, where the patient, on doing Perthes test, patient will complain of a crampy pain, sir, which indicates presence of deep vein thrombosis, sir. In modified Perthes, we see both on tying a tourniquet at the SFJ junction, sir, and we tell the patient to walk, sir. If there is shrinking of the veins, sir, then the deep system is said to be normal, sir. But if the veins become distended, then the deep system is said to be.
Is that Perthes? Is that modified Perthes?
Modified Perthes, sir.
No, that is not.
Sir.
Look, Perthes, I am occluding the deep system also, the superficial system, and then asking the patient to exercise.
Walk, sir.
Right?
Yes, sir.
In modified, in Perthes, we used to tie a H mark.
Okay, sir.
Right? So the patients used to just have pain. You couldn't see whether the veins are dilating or not.
Yes, sir.
That is why modified was done, where you tie a tourniquet so that you get both the pain and you can see the veins becoming
distended.
more prominent.
Yes, sir.
More prominent. So this is the difference.
Yes.
Right?
Okay. Yes. Sir.
You said, let's go back to your Saphenavarics kind of thing. Where do you say? You said cuff impulse. Morris's cuff impulse absent. And then on inspection, you said something about where's the inspection? Go to your previous slide. Is there a cuff impulse here? Is there a cuff impulse? Is there a saphenous varix here? What is
No, sir,
saphenous
I
varix?
didn't mention, sir.
What is saphenous
A
varix?
painless swelling at the saphenofemoral junction, sir.
It's a swelling.
Yes, sir.
When does it appear?
When there is on cough impulse, sir.
On coughing,
Yes, sir.
right?
Yes,
So
sir.
how will you differentiate this from, I say, a femoral hernia?
Okay.
How will you differentiate this from a femoral hernia?
The investigation Doppler, sir.
Hmm? Come again, please. Clinically, how will you differentiate this from a femoral hernia? Simple.
It arises from
Where is the femoral hernia situated?
below, sir.
In the femoral canal.
Femoral canal, sir.
Right. And where's the canal?
Uh,
It's the medial most portion,
yes, sir. To
the
the
femoral triangle.
femoral triangle,
And where
sir.
is this fellow? Where is saphenous varix?
Lateral, sir.
It's a defect in what?
Uh, in the cribriform.
It is covered by the cribriform fascia, but it's a
Cribriform, yes.
defect in what?
Um,
The fascia lata,
okay, sir.
right?
Yes, sir.
Okay. Okay. So
What is the
your
difference
Perthes
between
was
reducibility and
so,
compressibility? What is the difference between reducibility and compressibility?
Sir, when pressure is applied over the swelling, sir, the swelling is completely reduced, sir, completely reduced, sir. Whereas compressibility, as soon as the pressure is released, it comes back to the original.
Okay, so what will happen in a femoral hernia and what will happen in the saphenous varix?
Okay. Femoral is completely reducible, sir, whereas saphenous varix is compressible.
It is compressible, you know?
Yes, sir.
So that is another way of differentiating. Apart from the location, you can also differentiate by that also.
Yes, sir.
and of course the content. If it has bowel, you get gurgling sensation. Anyway, yeah.
Yes, sir.
Let's
Now,
go to your next slide.
can you tell
Sir.
the various tests which are there where you have to evacuate the vein before testing that, or where you have not to evacuate the vein before testing?
We empty the veins in Trendelenburg test, sir.
Yes.
Then we also empty it in the tourniquet test, sir.
Yes.
Uh, we empty it in the modified Perthes test as well, sir. We don't empty it in.
You empty in the modified Perthes test? Are you
No,
sure
we
about
don't
it?
empty it in the modified Perthes test, sir.
That is the only test where you do
Yes,
not.
sir. We don't empty the veins, sir.
While in rest of that, you
We
empty the
empty,
vein.
yes, sir.
And
then
also in Schwartz test, Schwartz you don't. You make the patient stand and just tap on it. You don't have to empty it.
Yes, sir. Impulses.
Yeah.
when you're doing the multiple tourniquet test,
Sir.
how do you open the tourniquet? In which order you are opening the tourniquet?
We open it from below upwards, sir.
From below, of course. Good.
Okay. Just tell me,
Sir.
Trendelenburg 1 and 2.
Sir.
How do you test for the do the Trendelenburg 1?
Sir, we make the patient lie supine, sir. We elevate the limb to empty the vein, sir. After emptying the vein, we either tie a tourniquet or we place a thumb over the saphenofemoral junction, sir. And we tell the patient to stand up, sir. On standing up, we immediately remove the pressure
No, you
at
don't
the
remove it. You don't immediately. This is what you don't immediately remove it. What do you look for?
Sir, first we look for rapid filling, sir.
You see whether it's filling from below upwards or not.
Yes, sir. If
right?
Yes, sir. Yes, sir. Then
When
after
you make the
removing the
patient,
pressure, if there is filling from above downwards, it indicates saphenofemoral incompetence, sir.
right. So Trendelenburg 1 can tell you both incompetent perforators and saphenofemoral. right?
Yes.
It's just not
Okay.
for saphenofemoral. Trendelenburg 2 is just to locate where the perforators are gone. Which perforators are gone?
Yes.
Okay, what are the types of perforators you know? What are direct perforators? What are indirect perforators?
Uh, Sir, direct perforators are perforators which connect the superficial to the deep venous system directly, sir. Whereas indirect perforators have plexus in between, or they pierce a muscle while
Plexus. There were plexus in between.
they pierce the muscle while connecting the superficial to the deep. This.
No, 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 no. Hang on, hang on. What is that? What is where do they open? Indirect perforators, where do they open? They
Uh,
open into the sinusoids
yes, sir.
and then they open into the thing. Okay,
Yes, sir.
right. You told us nothing about the short saphenous system. You just your examination. Just go to your inspection
Sir.
over the medial aspect, dilated tortuous veins.
Yes, sir.
Ritika,
Just,
where are
just
the perforators in the calf region? In which vein you get the main perforators?
Uh, Great saphenous, sir.
So,
Sir,
no, no. Sir wants to ask where do these perforators open? From short saphenous, where do they which where do they open?
no, from the GSV. Okay, let us take from the GSV, great saphenous vein.
sir.
There's a perforator.
Are
Where
they
is
on
it
the
going?
main trunk or not?
I, sir, I didn't get the question, sir.
What is Leonardo? Vein of Leonardo. Let's come to that.
Okay. Sir, Leonardo is a vein which is where all the below knee perforators drain into the Leonardo's vein, sir.
And where does Leonardo go?
Uh, Leonardo's goes into the great saphenous.
Goes to the great saphenous. So the blood is coming there through the perforators to the Leonardo and then back into the great saphenous. It
These
opens into the
perforators,
posterior tibial.
yeah.
Posterior tibial.
So these are
Right?
not on the main trunk, okay?
Yes,
These are
sir.
They
indirect.
are along the posterior tibial one. You know? All
Yes,
these
sir.
three perforators which are there, which you are testing,
Yes,
so
sir.
all they open in the posterior tibial, which is there, okay? Yeah.
Yes, sir.
Okay. Tell us the vessels at the saphenous opening. Could you see what are the veins at the saphenous opening?
Uh,
The anatomy.
Sir, at the saphenous opening, we have the great saphenous vein, sir, and its tributaries, sir.
What
Um,
tributaries?
Sir, we have the superficial inferior epigastric, superficial circumflex celiac, superficial external pudendal, sir, deep external pudendal, and anterior accessory great saphenous vein, sir.
And
Posterior.
that's it. What is this anterior accessory great saphenous vein? In the anterolateral and the anteromedial,
Yes, sir.
right?
Yes, sir.
So, so the anterolateral is the, I'm sorry,
Uh,
the anteromedial is the vein
the
of
accessory.
Giacomenes.
Giacomenes, sir.
Yeah. What is the importance of this vein?
Um, Sir, sometimes we,
Some fellows given his name, na? So there must be something different from other fellows. This
yes,
is
sir.
the one which connects the great saphenous to the short saphenous.
Short saphenous, yes, sir.
Right. Okay. You've told us
Hello.
nothing about the short saphenous system. Is it there, not there?
Sir.
What are primary varicosities? What are secondary varicosities?
Sir, primary varicosities are mainly due to uh, etiological valvular incompetence, sir. And secondary varicosities are secondary to any deep vein thrombosis, any
No,
prior,
no, no, no. Hang on.
sir.
Um, that is primary varicose veins and secondary varicose veins. I'm talking of primary varicosities and secondary varicosities. They're different. If you have dilated veins along the named, around the GSV is dilated, the
Yes,
short
sir.
saphenous is dilated, they are primary. You have bunches of veins which are away from these main veins.
Okay, sir.
They are called secondary varicosities.
Secondary varicosities, yes, sir.
So you've not mentioned us anything about that. Just show us a picture. you should have taken a picture from the posterior end also, no?
Yes, sir.
Neither you've mentioned it. I can see a vein in the just on the extreme right picture. There's a
Sir.
small swelling there. That could be a vein, you know, affecting the short saphenous. You've not even mentioned in your examination. Neither is it there in the picture,
I'll mention.
right?
Yes, sir. I'll mention it.
In the third picture, what
Okay,
can be the
let's.
origin? In the
Sir?
third picture,
Sir.
what are the possible reasons? As I said, there are some
Sir.
bunches of veins there. Am I right?
Yes, sir. Yes, sir.
Yeah. What are the possible origins from which it originated? Because it's important when you're treating it also,
Yes, sir.
to address the primary cause. Is it some GSV?
Yes, sir.
All are GSV?
From the GSV, sir.
Is it sure? Or anything else? Can be short
Yes.
surface also. High insertion short surface also can produce such a
Cranial
lesion.
extension of the short saphenous.
Yes, it's a high insertion because
Yes, sir.
only 30 to 40% of the saphenous short surface system opens into popliteal vein in the popliteal canal itself, and
Yes.
rest may be below or above. So this
Yes.
way from the above insertion. Okay.
Yes, sir.
Yes.
Okay, this patient
What is
has
accessory vein?
lipodermatous. Sorry.
Sir?
What is accessory vein? Vein of Giacomin?
Sir, it is the vein which it's a cranial extension of the short saphenous vein, sir,
Yeah.
which connects
When?
the short saphenous to the great saphenous vein, sir.
Okay, fine. Okay. Yes. Rajesh sir.
Yeah. The patient
Lipo?
has lipodermatosclerosis,
Sir.
right? What is lipodermatosclerosis?
Sir, it is fibrosis and obliteration or sclerosis of the skin and the subcutaneous tissue, sir, due to venous insufficiency, sir.
Okay. What is chronic venous insufficiency then? What is chronic venous insufficiency?
Sir, due to there is complete loss of valve. This thing.
Okay, tell me the difference between chronic venous insufficiency and venous hypertension.
So chronic venous insufficiency due to venous prolonged venous
What does
stasis.
the word say?
Sir,
In venous insufficiency. That means the
the
veins are working, but they're
yes,
not
sir.
working sufficiently.
Yes, sir.
So there's some pooling of blood all the time,
Yes, sir.
right? So how does the blood from the lower limb go back to the heart? What are the mechanisms?
Sir, through the deep venous system, sir, through the calf muscle pump, sir.
Okay, muscle pump.
Yes, sir.
Then
Um, during exercise also, sir.
Okay,
that
that's
is
one
again
system,
muscle pump.
one mechanism. Other mechanisms?
What are the other mechanisms? Something to do with respiration?
Yes, sir.
What? Yes, sir.
The pressure gradient, sir, due
So
to
what is pulling up?
the intrathoracic pressure.
Negative
When?
intrathoracic pressure
Thoracic pressure
on
and
respiration.
yes,
When?
And what is
Third
the third?
mechanism?
What is the third mechanism?
intrathoracic calf
What
muscle.
is vis a tergo? Have you heard of the term vis a tergo?
I have no idea, sir.
So the vein and artery are in one compartment. So
Okay,
when
sir.
the artery bulges up and down, it
Sir.
presses the vein
Yes, sir.
and pushes the blood up, and the valves are there, which
Yes,
prevents
sir.
it.
Yes,
Okay.
sir. Yes, sir.
So why do you think the SFJ is the first valve to be involved? Why do you think that happens? Why does the SFJ gets blown out first?
Because of the long column, sir.
Yes.
And
IVC's got no valves. The
yes, sir.
first valve between the heart and the
It's a
lower limb
single
is at the
large valve.
is the
There's
S,
it.
S
Yes.
at the SFJ.
Yes, sir.
So that's the first column, right?
Yes.
Varicose veins is because we are biped, you know, prolonged standing. Do you know any other diseases which is peculiar to humans because we stand on our 2 feet?
Mm. Varicose lump disease. I'm not sure, sir.
Yeah, because it doesn't happen in quadrupeds.
Yes, sir.
Which are the diseases on for a biped? Okay, verti- PIVD,
Sir.
intervertebral diseases, hernias, hemorrhoids,
Yes, sir.
right? Varicose veins,
Yes.
all that kind of thing, right?
So what is the
Okay.
difference between CVD and CVI? Chronic venous disease and chronic venous insufficiency. What is the difference?
Yeah, I left that.
Uh,
What is chronic venous disease and what is chronic venous insufficiency?
insufficiency is due to prolonged venous stasis, sir,
No, as Dr. Shah has
causing
told that once there is insufficiency is there, then that is called
sir.
a CVI. So if you
Yes,
look
sir.
at the SEEP classification,
Sir.
CVD is total from C0 to C6 is CVD. That's a chronic venous disease.
Yes, sir.
While CVI, which is there, chronic venous insufficiency is there, that is
Yes, sir.
from C3 onwards.
Yes, sir.
C1, 2 is not
C4 to
insufficient.
C6.
Okay.
C3. Yes, sir.
C3 onwards is the insufficiency. Yeah.
Yes, sir.
Okay.
You get an ulcer and it becomes chronic venous hypertension,
Yes.
chronic venous disease, right?
Yes, sir.
Okay, so tell us what is lipodermatosclerosis now? Why does it happen?
Sir, due to fibrosis and
No, no.
obliteration,
Why
sir, of
why should
the skin
fibrosis
and the
happen,
subcutaneous.
Richika? Why does fibrosis have to happen,
Uh,
Ritika? It doesn't happen on its own? When
yes,
will
sir.
fibrosis happen in any
Uh,
place in the body? When
uh,
there's
Sir, it is an inflammatory reaction
when there's
second due
inflammation
to.
and the body's trying to heal it, you get fibrosis,
Yes, sir.
right? So
Yes, sir.
how does fibrosis happen here? What happens? Why that discoloration is there? Was it
Uh,
black?
Sir, sir, due to venous high pressure, sir, in the venous system, there is a leak of RBCs, sir, through the capillaries. This RBCs, they are acted upon by the
No, no, hang on.
sir,
Why should RBC just walk out of the capillaries here?
due to increased pressure, sir.
So if I cough, there's pressure there, the RBC should walk out.
No, sir.
You have all those theories, no? Margination theory and all that kind of
Yes,
cough
sir.
theory and margination theory,
Yes, sir.
right?
White cell.
So
Yes, sir.
there's
Diabetes.
decreased oxygenation, there's decreased
Yes, sir.
nutrition going out. The fellow gets ischemia,
Yes, sir. There
fibrosis,
is a impediment to the
right?
exchange of nutrients and oxygen,
There's
sir,
less oxygenation,
leading
then the
to.
capillaries give way, the walls give way, then the RBCs walk out,
Yes, sir.
and then
Yes,
they
sir.
break down,
Yes, sir.
right? So
Yes, sir.
what is champagne
And
bottle?
it causes accumulation of hemoserum.
Right. So what is champagne bottle now?
Uh, Sir, there is narrowing at the ankle and calf muscle hypertrophy, sir, leading to verted champagne
Muscles
water,
are not hypertrophied.
sir.
It is there is constriction. There's constriction at the ankle,
From. Yes,
right?
sir. Yes, sir.
Right. Now the patient has those ulcers, right? They are
Yes, sir.
varicose ulcers, the venous ulcers. These are venous ulcers,
Yes, sir.
right?
Yes, sir.
Why do these ulcers happen on the gaiters area usually?
Um, sir, due to the
What's the
What is
important point
Linton's
is,
line? What is Linton's line?
sir, due to this stasis and vacuum, there is
No, it
lo-
happens on the
tissue
medial side,
hypoxia.
right? Gaiters
Yes,
area
sir.
is on the medial side. And what do you have on the medial side? You have the great saphenous vein,
Great saphenous. Yes, sir.
right? So this is known as the Linton's line, right?
Ritika, let us go back
So,
to our first question. Why venous ulcers? Yes, part of this question. Why venous ulcers doesn't occur on the foot? All of the examiners rejected the diagnosis of venous ulcer in the foot. Why? Any idea? Any guess?
No, sir. I'm not sure, sir.
Because when you are pushing, when you are walking or when you are putting the foot down, there's a pressure on it. That pressure will be transferred to the vein. So the blood will be pushed up. Okay. Theoretically, there's no possibility of venous hypertension in the foot. That's why a diagnosis of venous ulcer is not possible, at least not feasible in that foot.
so why do you think this patient had ulcer? Because I think he must be undergoing some sort of treatment. They must be applying some sort of lath or something which has made the skin break down.
Okay, sir.
You get me? He must be undergoing treatment. Come on, for 1 year, if he's having this, if he's progressed to this black condition, he must be undergoing treatment somewhere.
Yeah.
Was he?
Some ointments or false type of some bandages, false application of bandages, these all things happen.
Yes. Or he might be using a stocking wrongly.
Yes.
They might be putting some pressure stockings on it, pressure bandage on it. This is
How do you identify?
definitely
Yeah.
man-made.
Please, sir. Please, sir. Please, sir. Please, sir. Please.
Okay.
Artiga,
Now how do you manage this patient?
Okay.
Sir, please, sir.
How will you identify the right stockings for a patient?
Okay, tell us the class of stockings.
Yes.
What are the class of stockings?
Sir,
Yes, conclude.
there are 4 gradings, sir. Grade 1 stocking
There are 4
is
grades?
10 to... Yes, sir.
Okay.
Okay.
Grade 1 is 10 to 15, sir. 10 to 15 and grade 2 is 20 to 30, sir. Grade 3 is 30 to 40, sir. Grade 4 is more than 40, sir.
What
Ideally,
happens? What happens if you use more than 40? What's the problem of stockings with more than 40 pressure?
More than 40, sir, it will impede the supply to the limb, sir.
Supply of the?
What supply? What supply?
Arterial, sir.
Yeah.
Arterial, lymph flow, everything is obstructed. There is only 3 grades as far as we know.
3 grades,
Grade 1,
not
2,
4.
and 3. Yeah.
Okay,
4 is not there. Don't use the stockings more than 40. Okay, you are described to give a below knee stockings. How will you identify the size? You are the consultant.
We measure the ankle circumference.
Ankle where?
Sir?
Ankle where?
Ankle. I didn't get, sir. Circumference. We at the narrowest part of the ankle, sir. Above.
Then. You measure the circumference just above the ankle and the broadest part of the calf.
Calf, yes, sir.
Highest calf of the calf. These 2 are the measurements to be taken.
Yes, sir.
And these are labeled on the, if you look at every cover of that stockings, this must be there.
Yes, sir.
That's you have to decide the size. Because
Yes, sir.
our studies are told in the initial part, the wrong right stockings is a lot of difference. So you have to
Yes, sir.
give the right stockings. Maybe this patient may be using the wrong stockings also. How do you identify vasculitic ulcer to venous ulcer?
Sir, vasculitic ulcers are more painful, sir, and they involve
Yeah.
the deeper tissue, sir.
Then?
And uh, they are usually venous varicose ulcers are comparatively they are only involve the superficial tissue. They are painless, sir, and surgical treatment will usually reduce the.
No. Diagnosis. The patient is just in the OPD. You cannot treat unless you diagnose.
Uh, like typical areas, sir, gaiters area, we see the.
Yes, vasculitis are typical areas, multiple
Yes,
ulcers. There will be
yes,
other symptoms. There will be other features of vasculitis also. If that's there, let's think about a vasculitic ulcer.
punched out edges, sir, painful and involve the deeper
Yeah,
tissues.
yeah, more painful ulcers. Okay, now we'll move to management. How will you manage this patient?
Uh,
Dr. Jayesh, any questions?
Dr. Ritika, in the general examination, you told there is no pedal edema for the patient. Is it so?
uh, sir, yeah, they will.
So, why we expect pedal edema in case of chronic venous insufficiency?
Uh, because of venous cooling, sir.
Yes, there will be increased hydrostatic pressure,
Yes, sir.
and there will be at the start of the disease will be the advanced disease will be edema.
Yes, sir.
Afterwards, the patient may have a fibrotic leg, inverted champagne bottle.
Yes, sir.
There, it may appear that there is no edema for the patient.
Yes, sir.
Okay, move to well manage.
Uh, sir, sir, initial workup we get a Doppler scan done, duplex scan done, sir, with routine blood investigations, and based on that we proceed with minimally invasive surgery, sir.
For a Doppler,
Sir,
if you are doing a Doppler, what all things you look for?
uh,
How will you
sir,
do a Doppler in this patient position?
in the standing position, sir.
Okay.
Uh, uh,
What are the 5 points you look for in Doppler?
sir, superficial venous system, we look for the patency, sir, augmentation,
Yeah. Yes.
phasic,
Right.
this thing, and patency, augmentation, phasic, and
Okay. Super system has some patent issues, some obstructions are there. Will you take any different management?
no, sir, we won't operate in case of any uh, obstruction or deep vein thrombosis, sir.
So superficial system.
Uh,
Deep vein is patent, but superficial is not patent. Some
sir,
obstruction is there.
sir. Uh, yes, sir, we operate, sir.
Doesn't make any change.
Um, sir, I don't think I'll make it.
Because if any thrombus super system, better not to go for your minimally invasive procedures like laser RFA, because that probe may dislodge the clot and clot may go up. Can
Better
produce
go.
pulmonary embolism. Yeah. If the
Yes,
suspicious throat clots are there,
sir.
either you treat the clots and do the management, or you can straight away go for a surgery if the
Yes.
deep veins are patent. They are not the right candidates for a minimally invasive procedures. Okay, then
Yes,
If you
Doppler,
have to
yes.
see only one thing in the duplex scan,
sir.
what is the thing you want to see?
Only one thing in the
Yeah.
duplex and for DVT, sir.
Yes, right. So that is the
How will you,
number one thing, yeah, that you have to
Yeah.
see whether the DVT is there or not.
Yes, sir.
how do you know DVT is present or not in the Doppler?
Deep venous system.
Yeah, you are doing Doppler.
Yes, sir.
Sorry, saying there's DVT.
Sir.
How do you know there's DVT or not?
Non-compressibility of the vein, sir, with any
One is non-compressibility, then
yes, sir, any foci hyper
and
um,
Ritika, you'll see the thrombus on the B mode within the lumen.
yes, sir.
How do you say
then
that the saphenofemoral junction is incompetent?
Uh, Sir, we look for any thrills, sir, reflux, and
Which reflux you will say it is incompetent?
uh,
You
sir,
did it in
ideally
your
we,
examination.
sir,
You did that in your examination.
yes, sir.
No,
What do you do?
on duplex. On duplex scan, how do you say the saphenofemoral junction is incompetent?
We keep the probe at the saphenofemoral junction, sir, and we tell the patient to perform a Valsalva, sir, and we look for
You
reflux.
see for the reflux there, you know?
Yes, sir.
And you have to see how much is the length of that, duration of that. That is most
Yes, sir. More than 0.5
What is the
seconds.
more than 0.5 it should be there, then only.
Yes, sir.
If it is only
Yes, sir.
0.1 is there, you will not say it incompetent.
Yes, sir.
So it has to be more than 0.5.
Yes,
And
sir.
how to say it is a perforator incompetence?
Sir, it should be more than 0.3, and there should be a gap, this a gap of in the deep fascia of more than 3.5 mm, sir.
Yes. Yes. Now you sometimes measure the long saphenous vein, the diameter. So which is
Sir,
the best place to measure that?
best space to measure the uh, sir, in the
You use the mid thigh, you know?
mid thigh. Okay, sir.
Mid
why
thigh
you
is
are measuring it?
very
Why you are measuring it?
Sir,
What's the
uh,
purpose?
if the diameter is more than 2 centimeters, sir, we proceed with an open surgery, sir, rather than an endovenous.
Okay. Do this size alone is a criteria to manage without a reflux? What's the suggestion?
Sir,
Wait, VS is dilated, but there's no reflux. What to do?
vein is dilated with no reflux. I'm not even sure, sir.
There is no esophageal reflux. That doesn't
Yes.
mean there may be peripheral incompetence. That's why it gets dilated. So if that, even though there is the upper part is normal, if the peripheral is incompetent and the vein is dilated, in asymptomatic patient, he needs treatment. Okay.
Yes, sir. Yes, sir.
Doctor
okay?
Ritika,
Sir,
what is deep vein reflux?
deep vein reflux, sir.
Yes.
Um, sir,
Why is it important in managing varicose veins?
uh, sir, due to incompetent valves, sir.
Incompetent deep valves.
Yes,
And
sir.
we'll see for SFJ incompetence, we'll see for 500 millisecond incompetence. For D veins, we'll see for 1000 milliseconds. And what does it indicate?
Uh,
Patient might have had a previous
Post
DVT.
thrombotic previous history of deep vein thrombosis.
DVT. Okay.
Yes.
Sometimes when you do a Doppler, every vein will be patent. It doesn't mean that the patient didn't have a DVT previously. So sometimes the only finding we will get is D vein reflex. And for those patients, we will have to see for upstream any obstruction is there, iliac
Yes.
vein obstruction.
Yes, sir.
So we have to do other investigations for that patient.
Okay.
Otherwise, once you operate for the superficial veins also, we may cause the disease to progress for the patient.
Yes.
Okay,
Sometimes,
Ritika. Now that sir
yeah.
asked you about something, let me ask you: what is
Sir.
phlegmasia alba dolens and phlegmasia cerula dolens? Have you heard of it?
Yes, sir.
PAD, PCD.
Yes, sir. Any swollen limb in painful swollen limb will cause phlegmasia alba dolens, sir. And when the veins are completely obstructed, it will the limb will become bluish and congested, leading to phlegmasia cerulea dolens, sir.
No, so why does it phlegmasia alba means white leg?
Yes,
Why
sir.
does it become white?
Uh, it becomes swollen due to the and edematous, sir, due to the edema.
Due to edema.
Yes, sir. There is completely there is uh, loss of blood.
Let,
This thing, sir.
let me tell you.
Sir.
In phlegmasia alba dolens, the leg is white because there is extensive venous obstruction with arterial involvement, but the collaterals of the veins are intact.
Yes, sir.
So the art because the artery is involved, it becomes white. When it progresses and the venous collaterals are also obstructed,
Yes, sir.
this is a precursor to venous gangrene, and this is known as phlegmasia
Pernicious.
cerulea PCD,
Yes, sir.
right?
Yes, sir.
Dolens. Do you get it? So it
Yes, sir.
is just that in phlegmasia alba, the veins,
Arterial and
the blood is going back to the veins, but through the collateral veins.
yes, sir.
In cerulea,
There is
no
complete
blood is going back.
obstruction of the.
It's complete obstruction,
Uh,
right?
yes,
Both
sir.
the collaterals and the main vein. That
Yes,
is
sir.
why. Okay.
Yes, sir.
Okay. What is May-Thurner syndrome? Have you heard of
May-Thurner
this?
syndrome is yes, sir. Uh, non-thrombotic iliac vein compression, where the left iliac vein is compressed by the right iliac artery, sir.
Left iliac vein is compressed. Why does it do? Why does that happen?
Uh, Due to compression, sir. Basically, due to
Because the
angle.
left common iliac vein has to empty into the IVC, which
Yes,
is
sir.
on the right side.
Yes, sir.
So it goes below the common iliac artery and it's compressed.
Yes,
So
sir.
that is why venous diseases is more common on the left leg
Yes,
rather
sir.
than the right.
Yes, sir.
Okay, tell us the surgeries. How will you manage this patient? Quick.
Uh,
What are your options?
Sir, we do either an open approach or an endovascular approach, sir.
No, no,
Uh,
what will you do? What will you do?
Sir, I'll go with an endovascular laser ablation, sir.
Have you done it?
Uh, yes, sir.
Have you done it? Have you done it?
Yes, sir.
Then, yes, sir.
Sir,
Okay. Tell me what is tumescent anesthesia?
uh, tumescent is a combination of local anesthetic, sir, sodium bicarbonate, and normal saline, sir, which is given around the vein to which acts as a heat protectant, sir, and also creates pain, sir.
Any
Creates.
other any other advantage of doing consent?
One you said okay. It is act
Anesthetic,
like
so
open anesthetic.
anesthetic
What is the other what are the other
heat,
uses of it?
heat, it absorbs it, sir.
It keeps a distance between the skin and the vein so that heat
Yes,
transmission
sir.
to skin is
Prevents.
So it
protected.
prevents the heat from
Yeah.
going into the skin.
Yes, sir.
Because
And it
And the
creates.
what
last,
else? What else?
yes,
What else?
It creates a. It separates a plane, sir, and
yes,
No,
absorbs
no.
the
that's
excess heat, sir.
It compresses the veins,
yes.
Yes, sir.
right?
What
So it
Yes.
empties
what
the vein.
Yes, sir.
what happens if it's not properly compressed?
Um, the ablation, it won't get the vein wouldn't get.
Yes, ablation won't happen.
Yes,
So
sir.
early failure. Then anything else?
Um, Excess of heat will cause damage to the surrounding.
No. Not compressed. You are given percent. The distance
Sir.
between the skin and the vein is adequate, but it is
Yes,
not
sir.
properly
Cause
compressed.
skin.
Eh?
Sir.
Vein
Suppose
is
the
not
vein is
adequately
not
compressed.
completely compressed. What will happen?
The vein wouldn't ablate, sir. And
There'll be blood inside.
yes, sir.
So what will happen to that?
It would become a clot, thrombus, sir.
Then what are the
Right.
problems of clot?
It may go embolize and
One is
clot.
it may early embolization, then
Yes, sir.
long time.
Any
It forms a clot around that laser fiber. After
sir.
some time, if it is not embolized, it may disintegrate. So
Yes, sir.
that once clot disintegrate, again the vein will patent. So
Recurrence.
early embolization, late recurrence. So there should not be any amount of blood between the catheter and your vein when you're doing a laser RFA. That's very important.
Yes, sir.
2% is very important.
How many joules do you give? How many? You said you've done it. How many joules do you give?
Sir, we give around 60 to 80 joules per centimeter, sir.
How many bursts?
Sir,
How many bursts of 60 joules or 80 joules?
uh, sir, every 1 centimeter continuous we give, sir.
So give 2 to 4 bursts
Okay, sir.
at every set. And how do you, where is the catheter placed? Where do you
Uh,
start from?
we start above the medial malleolus, sir.
You start
And
from the
we
medial malleus.
Yes, sir. We give a incision at the medial malleolus. We insert the laser fiber, sir, up till the from 2 centimeters from below the saphenofemoral junction, sir, and we start
Why 2
ablating, sir.
centimeters? Why 2 centimeters
Sir,
away?
to prevent injury to the femoral vein, sir. Deep
To
vessel.
prevent
Deep.
injury. Right. So what's the problem with this then?
Uh,
What's the problem with this? 2 centimeters. What's the danger?
to prevent injury to the femoral vein,
No,
sir.
no, that way, no.
Femoral
That
vein
way you said
thrombosis.
there are tributaries there,
Yes, sir.
which you're going to miss,
Yes, sir.
right?
That will be the cause of
So
recurrence.
that's the major cause for recurrence after laser.
Okay.
Okay.
Sir. Okay.
Okay.
Sir.
What are the other options? What is SCP?
Uh, SCP is subfacial endoscopic perforator surgery, sir, where we insert an endoscopic probe and we use it to
Endoscopic
ligate the
probe.
perforate.
Endoscopic probe.
Endoscope, sir. Endoscope, and
Yeah.
we use it to ligate the
Where
perforate.
do you place the scope?
Uh,
What's the plane of dissection?
Subfacial, sir.
Is it above or below the vein?
Uh, Above the vein, sir.
Is this superficial to the superficial veins or deep to the superficial? That's what I was asking.
Okay.
What are
Deep, sir.
ligating with
Deep,
the
sir.
steps? Pardon?
The name
Uh,
says it, no?
Subfacial,
Nitika?
sir. Yes, sir.
Yeah, below the fascia.
Yes, sir.
These veins, these GSP is above the fascia,
Yes,
isn't
sir.
it?
So below. Yes, sir.
Place it below
So
the fascia.
your
Yes.
identity for the perforators just at the perforated perforated part of the deep fascia. Okay, that's why you're
Yes, sir.
doing it. Okay,
Yes, sir.
fine. You can clip it there.
What is what is when do you put injection sclerotherapy? What is sclerotherapy? When is it
Uh,
done?
Sir, we usually give it in case of any spider veins, telangiectasia or reticular veins, sir, and it is given in the
No, it's
it
not given
is
in varicose veins.
no, sir, it is given in spider
Of course,
veins,
it's
sir,
given in
vein
varicose.
thread veins,
No,
sir.
no, 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 no. It is given in varicose veins also,
Uh, yes, sir.
right? Now, how do you
Yes,
do
sir.
it? How do you
Sir,
do
we
it?
there is a specific method to we create a foam. It is also known as foam sclerotherapy, sir, where we create a ratio of 1:3 of
What is
sclerosant
that
and
method
air, sir.
called? What is that method called?
Sir, it is known as the Tessera's method of
Sorry, method. Why do you have to make a foam? What is the advantage of foam?
uh, sir, because it gives complete coverage of the this thing, sir. And also we use a very
Covers a
more
larger surface area with
yes,
a
sir.
smaller amount of sclerosant,
Yes, sir.
and it displaces
What
the blood
investigation?
also.
What investigation will you do essentially before doing form?
What investigation?
What is investigation should be done
Sir.
before you are doing form zero?
What is the most important thing which you have to do to before doing sclerotherapy?
Uh,
Before doing any surgery for varicoses, okay, let me put it that way. The deep vein has to be patent.
okay.
So
Yes,
you
sir.
got to make sure that
Sir.
the sclerosant doesn't go into the deep vein.
Yes, sir. Yes, sir.
What sclerosant is used? What sclerosant is used?
Sir, we use sodium tetradecyl sulfate, sir. And or
More importantly now,
polydecanol.
polydecanol.
Yes, sir.
Polydecanol.
Yes,
Right?
sir.
Right.
I
And
didn't
how
get
do you
to
do it?
Sir, we
Have you
yes, sir.
Yeah, how do you do it?
Using a three-way cannula, we create a foam using in a 1:3 ratio, sir. Of
Yeah, you've done it. Created.
Sir.
Then now what else now?
Uh,
How much do you inject?
uh, we give 0.1 ml, sir.
You cannot inject more than 10 to 12 ml in one sitting.
Yes, sir.
How do you inject? How do you inject?
The-
Have you seen it?
uh,
You make the
no, sir.
patient stand
Yes,
and
sir.
you push in a couple of venflons into the varicosities,
Yes, sir.
right?
Yes, sir.
And then you remove the needle and push in about 0.5 ml of foam in each.
Yes, sir.
So you can get 4 or 5 of them and you push in about 1 ml or 1.5 ml in each, right?
Yes, sir.
And then you remove the cannula and you press it.
Yes, sir.
Similarly, you do
Ritika,
it in 3 or 4.
Yes, sir.
Ritika, I only have to do a echocardiogram of this patient because if a patient has a right to left shunt, then this is risky. Patient may go in for stroke. So at least on theory part, you should do a echocardiogram before doing a sclerotherapy.
Yes,
Second
sir.
thing is when you're doing it, do follow up with ultrasound probe so that
Sir.
that will help you not to the form not to leak in the deep vein. You can compress there 2 to 3 minutes so that form gets settled there. It won't
Yes, sir.
move to the deep veins. These are very
Yes, sir.
important.
Yes, sir.
What's the microform?
I've heard about it, sir, but I'm not exactly sure, sir.
Microform is usually in your tensile technique, you keep the valves completely open. Okay?
Okay, sir.
Microform is something if you keep the valves 1/3 open, you
Yes,
get low size forms. So some people say that's better.
yes, sir.
What is the ideal gas to mix with polyolefin to form this form?
Sir, ideal?
Yes. Oh, to make a foam, what's ideal
Sir.
gas?
Carbon dioxide, sir.
Yes, because that will get absorbed even though it goes up.
Yes, sir.
Let's say.
Okay, I think we've done 10-20. Well done, Ratika.
Thank
Do
you,
you
sir.
have any questions?
Dr. Jayesh, any questions? What is the supplement sparing procedures?
Sir? I
Can you
didn't
have
get
some?
it, sir.
Yeah.
Sir, I didn't get the question, sir.
What are saphenous sparing procedures?
Saphenous sparing procedures. Perforator ligation, sir? Or HIFU, sir?
Because some people say the saphenous vein is very important
Sir.
for a future CAB from that or a thrombo bypass. So you should not remove the complete saphenous veins. So they suggest treatment of the affected perforator along with the affected saphenous segment, not the complete saphenous vein is removed.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Yeah, but now saphenous vein is hardly used for CABG. It's the
Yes,
arterial
sir.
this thing. So
Almost.
okay, suppose this patient saphenous femoral junction was competent and had incompetent perforators. What would you do?
We just proceed with the perforator ligation, sir.
Okay, and the patient comes back to you after a couple of years with blown out saphenous vein, saphenous opening.
Dr. Jayesh, you said something else?
So you have to do a saphenofemoral ligation, even if the saphenofemoral junction is intact in varicose veins. Otherwise, the patient is going to have recurrence.
Yes, sir.
There's nothing.
Dr.
Okay, what?
Latika,
Sir.
which is the recommended procedure for truncal veins, GSP and SSV, which is the recommended procedure according to the guidelines?
For great saphenous and short saphenous, endovenous, sir. Endovenous laser ablation, sir.
Endovenous thermal ablation can be laser, can be RFA.
Yes, sir.
And when is the surgery recommended?
In case of in case of incompetency,
Where you cannot do these procedures, like you are having a huge sapina valley.
when the diameter is more than 2 centimeters, sir.
Yes, and sapina varies. Or there is a sign case. I'll ask you about the superficial vein thrombophlebitis. Once it resolves, there may be residual sign case. So we cannot pass the catheter.
Yes, sir.
So what is the difference between recurrence in open surgery and in endovenous thermal ablation?
Sir, in endovenous, it could be because of the vein not getting ablated properly, sir. Whereas in open surgery, it could be because of any accessory vein.
Both sides there will be a technical fault. The correct answer is that when you are doing endovenous thermal ablation, the recurrence is mostly due to recanalization. After you done the surgery, again the vein recanalize and
Yes, sir.
cause recurrence. And in
Okay,
case
sir.
of open surgery, after you ligate all the tributaries and GSP,
Sir.
there may be neovascularization.
Okay.
New veins will be formed.
Yes, sir.
So if the new veins forms, what do you do?
We won't.
Then you
Sir,
do a
we,
thrombectomy. You phlebectomy. You put in a small
yes, sir.
hook up the veins, and then ligate
Phlebectomy. Yes, sir.
them. Do a phlebectomy.
Yes, sir.
So,
Ritika,
anything else?
Ritika, do you know what is EHIT? EHIT?
Sure. Endovenous heat-induced thrombus, sir. It is a complication of endovenous laser ablation, sir.
And that is why you keep at least 2 centimeter
Yes, sir.
proximal to the saphenofemoral junction.
Yes, sir.
Avoid this complication.
Yes, sir.
Now, as far as sclerotherapy which is concerned,
Yes, sir.
what are the special types of sclerotherapy which are done nowadays?
Uh,
Now,
there is a
majority of the time you do ultrasound guided, you know.
ultrasound guided. Yes, sir.
And then there is a catheter directed sclerotherapy also
Okay, sir.
for the truncal veins.
Yes, sir.
For the non-truncal veins or the spider veins or the telangiectasia which is there,
Sir.
you can do a direct puncture of that and
Yes,
do
sir.
the sclerotherapy.
Yes, sir.
So what concentration you use if it is you are using for the spider veins or telangiectasia and for the main truncal veins?
A
What is the
diluted.
difference in the concentration of the various sclerosants which is there?
Okay, sir.
You said
0.25%
you said
of
a sodium tetrahydrosis sulfate, no? In what concentration it comes?
1% concentration will be available, sir.
No, it is not available. You know? Available is only 3%. You know? Okay, available is only 3%, which we use for the truncal veins. But
Okay,
for
sir.
the spider veins, you have to use 0.5 to 1%.
0.5, yes, sir. 0.
Yeah. And another advantage of using the foam sclerotherapy is that you can detect it on the ultrasound. The foam which is there, you can see. If
Yes.
it is a liquid one is there, you
Sir.
cannot see on the ultrasound. But the foam is there, it can be seen on the ultrasound.
Yes, sir.
This tumescent anesthesia, what is the name of that? Do you know? What is the name of this tumescence anesthesia which is there?
Sure. It is a mixture of Lignocaine, sodium bicarbonate, and normal saline, sir.
What is that solution called as? It's called the Klein salt. Klein.
Okay, sir.
Okay. What is a physician compounded sclerotherapy?
I'm not sure.
What we do as a Tassari technique, that is a physician compounded.
Okay,
That
sir.
foam which you are making.
Yes, sir.
There are now special machines which are there and special foams are available.
Yes,
One
sir.
of them called the Verithena.
Okay, sir.
That is a come from the factory as such.
Okay, sir.
So that foam which is there, that is very good foam in form of that it does not cause a lot of the thrombosis. Okay, but majority of the time we are using the Tassari technique which is there.
Yes, sir.
Okay.
Dr. Ritika, do you know any other treatments?
Ma'am, we can go
Newer
with
ones?
ma'am.
Tell me some of the newer ones.
Ma'am, there is cryolaser ablation with sclerotherapy, ma'am. There is also MOCA, ma'am, mechanico-chemical ablation.
And one more. Vinasil? Glue?
Yes, ma'am. Cyanoacrylate glue, ma'am.
Yeah.
Yes.
What is the advantage of the glue?
Ma'am, it is not painful.
Yeah. So number one, you don't need tumescent anesthesia.
Yes, ma'am.
And there's no downtime as such for the procedure.
Yes, ma'am.
And only at the time of puncture, when
Yes,
you're
ma'am.
inserting the sheath, you
Yes,
require
ma'am.
local anesthesia up to that part. And post-op also, you will not have any kind of pain. But with Venasil, there are some reported allergic reactions. Okay, because whatever said and done, it is a foreign body that is being introduced into the body.
Yes.
Okay.
When you do this glue injection,
Sir.
you know where do you put the catheter? Like in case of laser, you put at least 2 centimeters away from the.
We keep 5 centimeters away from the saphenophyseal junction.
Keep at least 5 centimeters.
Yes, sir.
Because by the way, if this glue goes into the deep sense, then
Yes.
there's a real problem is there.
Yes, sir.
You have to always avoid that. What is HIFU? HIFU?
High intensity focused ultrasound, where high frequency sonograph is used to.
Is it a treatment for the varicose veins or not?
Yes, sir.
Yes, it can be, though it is available, not available in India.
Yes,
but
sir.
this is also one of the treatments for the
Yes, sir.
varicose.
Yes,
It's
sir.
called a non-invasive. So basically, you can have the thermal, you can have the non-thermal, and
Yes,
then
sir.
you get the non-invasive type.
Yes, sir.
What are the other thermals apart from the laser and the RFA?
I'm not exactly sure, sir.
You can use the microwave.
Okay, sir.
Or you can use the steam.
Steam sclerotherapy.
Steam, is what that.
Yes, sir.
Okay. I think we should. Dr. Kanagavli is there?
Yes, sir.
Yes.
Yeah. Any other faculty would like to ask anything, madam, sirs? Sridhar sir, your closing comments, sir. I think if thank you for permitting your students today.
Sir, thank you for the opportunity, sir. How do you rate our students, sir? They are just second year students, sir. Still, they have not come into final year.
Sir, you have very eminent examiners today asking questions. So let them comment, sir. Nicola, ma'am.
So I think I'll be a little
Brampton, ma'am, sir.
biased if I had to say anything. But I think they just need to brush up on their theory also to be able to answer a few of those questions, like the definitions and the differences between two different things. And I think a lot of reading needs to go into a little bit of journals as well, to, maybe change some practices and, whatever questions that we need to ask. Because I think when I was talking to them in the evening, I actually, Ritika asked me a question, in fact, saying, should we operate if the ulcer is there, if the venous ulcer is there, should we be able to operate on these patients? So that was the time when I told her that there's quite an old trial called EVRA trial done by one Dr. M.S. Gohar, which states that, you can do these early reflux ablations for the venous ulcers to heal better. So I think they need to do a little bit of the journal readings as well, so that they're up to date and, can do better with their treatments also.
No, I
Point
would
is
like
well
to come in,
taken.
ma'am.
No, sir.
The ulcer will not heal if the pressure is still there.
Yes,
So we have
absolutely.
to go in for surgery and treat the ulcer separately. The surgery has to be done. We don't wait for the ulcer to heal before doing
Correct.
surgery.
Correct.
Before, right? They are
Yes.
two different entities. The basic problem is the ulcer, the varicose cities, which have to be treated. The ulcer goes away, is treated on its own.
Correct.
Okay, by doing the early ablation, you have a faster healing of the venous ulcer, and you also delay the recurrence of the ulcer.
Yes.
Both of the things which are there. So I think all the patients with the venous ulcer, they should undergo for the truncal ablation if it is there. Otherwise, you can inject the what is called a sub-ulcer injection, which are there. The sclerotherapy can be done underneath the venous ulcers.
On the ulcer bed, yes.
Yeah, ulcer bed, yeah.
Okay.
We conclude, sir.
Dr. K, I think we should call it a day. Thank you so much, Ritika. Thank you so
Thank you,
much,
sir.
everyone. Good night, everyone. So, Dr. Carnival, we are closing up.
Yes,
Well,
sir.
sir,
I'm
Puro.
here. I think my network is not all right. So thank you, everyone. Thank you, all the faculty. Dr. Jayesh sir has been kindly brought in by Dr. Srikumar sir in the last moment as the other faculty could not come. I also thank Swaminathan sir, Nikhila ma'am, both the students, especially Dr. Shamya and Dr. Ritika, Sridhar sir, Sakai sir, Kanna sir, Jailal sir, and other senior faculty who have joined this today. And we wish to meet you all in the next upcoming Friday. Thank you very much. Good night, everyone.
And sir, congratulations for the
Good night, sir.
300th
Thank you. Thank
anniversary.
you, Dr. Karavel, sir,
Sir,
and
you should get,
congratulations for
Yeah,
this
thank you
wonderful
so
effort.
much.
sir, it's not on me, sir, not
Yes.
every one of us, sir. That's what I
No,
would say. This
you
has been a,
only lead us.
thank you so much, sir. Thank you, sir.
Thank you, sir.
Thanks for
Good night.
accepting our any request. That is all I should put on record. Thank you very much,
Thank
sir.
you, sir.
Good night, sir.
Good night.
Good night.
Good night, sir.